Very good afternoon and greetings to everyone here. Honorable professors, distinguished guests, warmly welcome and thank you for joining this afternoon event. Hybrid Symposium on Rapid Replenishment of Iron Stores on 27 July 2025 at Melia Hotel, Yangon. I am Dr. Mimo Mojo, Specialist Assistant Surgeon, Obstetric and Gynecology, Central Women Hospital, Yangon, and I will be MC of the today event. First of all, I would like to announce the agenda. Agenda 1, opening address by Professor Wei Ang. Agenda 2, redefining ion therapy, the clinical power of various carboxymaltose by Professor Dr. Sidra Japakan. Agenda 3, introduction by Professor Uzo Lin Ao. Agenda 4, anemia and iron deficiency in heart failure, chronic kidney disease by Professor Uhen Yaza Ao. Agenda 5, update management of iron deficiency anemia in pregnancy, expert opinion by Professor Umyo Nini. Agenda 6, question and answer section. Agenda 7, roundup and closing remarks by Professor Uzo Lin Ao. Agenda 8, brief broader presentation. Agenda 9, vote of thanks. Agenda 10, thanks give to chairpersons and speakers. Agenda 11, lucky draw program. It's time to officially begin our program. To deliver the opening address, I would like to invite our respected chairpersons, Professor Wu Yang, Patron of Myanmar Obstetric and Gynecology, President of Myanmar Medical Association, and Professor Wu Lin Ao.
Uh, Good afternoon, ladies and gentlemen. I'm delighted to be here today on this academic talk on the rapid replenish of iron stores. It is also a great honor to have Professor Zhou Liao as my co-chair today. Professor Zhou Liao is retired professor of medicine, former president of IRC, Royal College of Physicians, and he is now a consultant in the Bohosi Private Hospital and clinical director in internal medicine in Panlai International Hospital. Today, we are going to look into two aspects. One is from the obs and gynae point of view of iron deficiency, anemia, and correction of anemia during the pregnancy. And then iron replenishment by the Dr. Kenya Saang from the medical point of view, sharing his view on anemia and iron deficiency to heart failure and chronic liver diseases. Today, we have a distinguished speaker from Pakistan, Professor Dr. Sidra Jaba Khan, consultant obstetrician gynecologist, Northwest General Hospital, Peshawar, Pakistan. Professor Dr. Sidra Java Khan is working as a consultant obstetrician and gynecologist in Northwest General Hospital. She is also a member of the expert panel of specialists in that hospital under the Alliance Healthcare to elevate healthcare in the Khyber Pakhtunkhwa. She has also published numerous scientific papers in the pelvic preterm birth, laparoscopic abdominal and vaginal hysterectomy, and very interesting paper on undergraduate medical education. Today, she will be sharing her experience on redefining iron therapy, the clinical power of ferric carboxymaltose. We have with us today a distinguished Professor Penya Aung and Professor Muni after this speaker. May I call upon the first speaker to the stage to present her presentation, please?
Thank you so much, Siaji, for your wonderful introduction. Moving on, may I kindly invite Professor Uzolin Am, Senior Consultant Physician, Clinical Director, Penline International Hospital. Please, Siaji, take the seat on the stage.
Bismillahirrahmanirrahim. Very good afternoon, ladies and gentlemen. I'm honored to be here and thank you very much for coming on a Sunday to listen to whatever I have to say. And I really appreciate the presence of the senior obstetricians and gynecologists and other physicians coming to this session. This shows your interest in the subject, and obviously your juniors are going to follow this. So I'm very grateful to you. Uh, Coming to the topic for today's discussion, which is basically iron deficiency anemia and then iron carboxymaltose as part of the management for it. First, we'll talk a bit about the iron deficiency anemia. We know that more than 2 billion people worldwide have anemia. And this is the most common nutritional deficiency and is one of the 5 leading causes of years lived with disability burden. And for women, this is the first. Sorry. It's all right. So the prevalence especially high in women and children. For women, about 20%, and for children, it's about 42%. It's a big public health challenge for many low and middle income countries with long-term negative consequences for health, social, and economic development. Obviously, when there is anemia, so there are clinical consequences of it, when we are all very familiar with it, because this is the region where South Asia is the region where anemia is very common. So most of our patients, you must have seen in your clinical practice, complaining of fatigue, impaired cognitive function, compromised immune function, and reduced work capacity and productivity. So it basically affects the quality of life of our patients and carries substantial socioeconomic burden on the healthcare system. Taking the world population as about 8 million, so about 1/3 have anemia. And we are talking about more than 2 billion people. And of those anemic patients, half are iron deficiency anemia. So what is anemia? It is basically defined as hemoglobin 2 standard deviation below the mean for a healthy age-related population. It is either reduced RBCs or there is reduced concentration of hemoglobin in those RBCs. WHO and British Society of Hematology and CDC have taken 11 grams per deciliter as the minimum of the hemoglobin concentration for pregnant women. According to this, 40% of our women are anemic, and 1/3 of all the women of childbearing age, they are also anemic. So this is the scope of the topic, that we are dealing with a huge problem. And why is anemia important? Because this contributes towards the maternal mortality ratio. We all know what is maternal mortality ratio, which is the number of women dying of pregnancy, childbirth, or within 42 weeks after delivery per 100,000 live births. And overall, it's quite high. And WHO Sustainable Development Goals 3.1 states that the maternal mortality should be reduced. Giving you a few, just the idea of different countries having. So Pakistan has 186 per 186 deaths per 100,000 live births. Myanmar has 179, India has 176. So this is almost the same in this region. The good ones are the Finland and the Greece, only 3 women dying of 100,000 per live births. And Iran and USA are the same, the two friends. And then our neighboring country, we know the conditions there because of the very obvious reasons. Their infrastructure is not good and their health services are not good. So their maternal mortality is higher than ours, but it is still better than Sierra Leone, where it is 1360. So you can see the range that it's basically different areas of the world, the low and the middle income countries that have higher maternal mortality. And in Pakistan, the MMR is 26% higher in the rural than in the urban areas. And studies quote that about 20% of maternal deaths are because of the anemia, but then anemia indirectly contributes to some other causes of maternal mortality as well. Like you see, this is the indirect, anemia comes here in this 20%, but we all know that anemic patients are prone to develop infections. So this anemia contributes here as well. And just imagine a woman of 7 gram per deciliter and she starts having APH or PPH. So you can imagine the bleeding and the consequences of that bleeding. That's a nightmare for us if we have 7 gram. When my PG tells me that she has a 7 gram HB and she has started bleeding. So it's a big nightmare for us. And unsafe abortion. So indirectly, anemia is contributing to most of these causes of maternal mortality. So if we take care of anemia, we are definitely going to reduce the MMR. Now coming to the changes, hematological changes during pregnancy. We all know that pregnancy is a physiological condition and the body adopts to the change, and there are physiological changes in it. So in blood, we see plasma volume expansion during pregnancy of about 1 to 1.5 liter during those 9 months. And 50% of this increase occurs in the first 34 weeks, and rest of that follows after it. And this is very positively associated with the birth weight of the baby. Although the plasma volume increases, but the red cell mass doesn't increase in the same ratio, so there is hemodilutional effect. And we see fall in hemoglobin, hematocrit, and red cell count on the blood film. But interestingly, MCV and MCHC remains the same. In pregnancy, there's increased requirement of iron. And it is about 2 to 3 times higher than the other non-pregnant women. And this is required not only for hemoglobin synthesis, but for the working of certain enzymes and for the growing fetus as well. Along with iron, we know that we need folic acid. So the folate requirement is increased 10 to 20%. And there is twofold increase in the requirement of vitamin B12 as well. Now, many of our women, they enter pregnancy with the depleted stores. So even with a good HB, but depleted stores, they will end up in iron deficiency anemia as the pregnancy progresses. So what to do about it? There is prevention with oral and folate supplementation, at least in those with high risk of becoming anemic. And all women planning for pregnancy, if you happen to see them in the pre-pregnancy area, should be advised 0.4 milligram of folic acid, not as part of the prevention of anemia, but for prevention of the neural tube defects of the baby as well. The maximum rise achievable with iron is 0.8 gram per 100 ml per week. No, there was an interesting nutritional survey, a national nutritional survey in Pakistan in 2018, which defined the nutritional deficiencies, but I've picked up only anemia and iron deficiency anemia from it. So in children from 6 to 59 years of age, 60 to 59 months of age, anemia was seen in 53%, and iron deficiency anemia was seen in 28. So half the cases were because of the iron deficiency. And same was for the women of reproductive age, where 42.7% were anemic and iron deficiency was 18.2%. The other very important cause of anemia in our area are the hemoglobinopathies, and especially the thalassemias, both the alpha and the beta. They are the second important cause of anemia, but we'll be focusing here on the iron deficiency anemia. And pregnant women, there was a research conducted by AQ, Khan University Hospital, and during their study, they found that in pregnant women, the range of anemia was 28 to 50%. But then there was another study conducted in Pakistan, and this stated that the prevalence of anemia among pregnant female in Pakistan was 70.4%. So about two-thirds women were anemic. And I'm just quoting the Pakistani studies or maybe some Indian studies, but basically it's the same for the whole South Asian countries. In Myanmar, the overprevalence of anemia in women of reproductive age is 46.5, and this was documented by Myanmar Demographic and Health Survey, which was conducted in 2015 and 16. And almost half of the pregnant women were anemic, according to this survey. WHO has categorized the severity of anemia. So 11 or more than 11 is considered normal. So between 10 and 11 is the mild form of anemia. Between 8 and 10 is the moderate, and severe would be between 6.5 and 8 grams per 100 ml of blood. But the very severe ones would be less than 6.5. CDC has again their normal values for cutoff normal values for different trimesters. So in the first trimester, it's 11, while it's in the second, it is 10.5, and this is because of the hemodilutional effect that I just discussed. And then again, in the third trimester, it is 11 gram. So this is basically telling you about the anemia and effect of anemia on the health of the women as whole, and then on the pregnant women. And of course, they will transfer that, the healthy mothers will produce healthy babies, and the anemic mothers will produce anemic babies. Causes are basically nutritional, both the iron, the folate, and the vitamin B12, acute and chronic inflammation. Parasitic infections are very common in our setup. Hemoglobinopathies, hemorrhagic, hemolytic anemias, iron malabsorption, blood loss or menstrual blood loss. Exclusively breastfed infants are usually anemic. Those not getting supplemental food after 6 months of age, they end up in anemias. Pregnancy and repeated pregnancies, one after the other without any spacing, that's another big cause of iron deficiency anemia. And of course, cancers are there. So causes are variable, but of all those causes, more than 50% are because of the iron deficiency. And this is more, the prevalence is highest in South Asia, Central and Western Africa, basically the Sub-Saharan Africa. And this is from the WHO Global Nutrition Target Anemia Policy Brief. So if there's a woman with anemia, what has happened? It means that there is less number of RBCs, less concentration of hemoglobin and hematocrits. And what does it do? It diminishes the oxygen carrying capacity. So the hypoxia develops, and that hypoxia-induced effects are seen on different organs. And then they develop signs and symptoms of anemia. These are the common signs and symptoms that are there: dizziness, arrhythmias, shortness of breath, fatigue, cold skin, paleness, chest pain, headaches. And I'm sure that most of us, we feel these symptoms as well by the end of the day, especially. So what to do about it? Anemia is a big problem. We have understood that, but how to go around this problem and what to do about it? So besides improving the nutrition, obviously, the pharmacological management will include iron therapy in the form of oral or parenteral, blood transfusions, and then treating the underlying cause, which is the reason for anemia. In case of oral iron, our Society of Obs and Gynae in Pakistan has developed guidelines. It issued these guidelines in the latest was in 2022. And according to that, oral iron intake of 30 to 60 milligrams and folic acid 0.4 milligram for pregnant women to prevent maternal anemia, puerperal sepsis, low birth weight, and preterm birth. Oral iron therapy is in the form of ferrous sulfate, ferrous fumarate, gluconate, iron polymaltose complex, and liposomal iron. Parenteral therapy is indicated to pregnant women where iron requirement is increased and there is poor compliance with oral iron. Oral iron compliance is a big issue. Most of our patients, they complain of nausea, vomiting, and upset tummy, acidity, loose motions, and some even complain of constipation with it. So when the compliance becomes poor, you have no other option but to go for the IV route. Available options are iron sucrose complex, iron polymaltose, iron isomaltoside, and ferric carboxymaltose complex. The high dose of iron infusion, it has its benefits, and benefits are for the patients and for the health service providers, the hospital, and there are other benefits as well. For patient, there is less disruption of life. Patient has to come just once or at the max twice to get the high dose of iron, and that's it. And then she goes back. She doesn't have to come every third day for getting IV infusion, which will disrupt the life at home, and somebody has to bring her in. Most of our women are man dependent, so the husband has to take time off from the hospital, bring her in, get her this IV infusion, then go back, drop her, and may or may not go back to work. So the efficiency of the husband at work is also affected by anemia of her wife at home. So she also has to spend less time away from the home or her work, and reduced number of injections and fewer side effects. While with for the hospital, there is reduced number of visits, so the workload is reduced. There reduced physician and nurse time, and though physicians and nurses can do something more important and better for the patients, improved outpatient management, and there is improved cost effectiveness. By the end of the day, it is cost effective for the patient. Other benefits are reduction in treatment period, higher ferritin levels, and delay in the recurrence of iron deficiency anemia if the underlying cause is not corrected. Guidelines for iron deficiency anemia in pregnancy and postpartum is that our SOGP has advised high dose iron, ferric carboxymaltose to pregnant women in second and third trimester, and it can also be given as a single shot in the postpartum period. Then the BMC Women Health has recommended 1 gram, which is 2 vials of FCM infusion, and safe and effective in the treatment of iron deficiency anemia. And it improves lab biomarkers like hemoglobin, MCV, serum iron, serum ferritin, total iron binding capacity, and transferrin levels, and restores the iron stores in short duration of time as compared to iron sucrose. American Journal of Obs and Gynae mentioned that IV iron ferric carboxymaltose was safe and well tolerated with a superior efficacy in the treatment of postpartum iron deficiency. This is supported by many studies done in our region, one of that done in India. It says that infusion prior to delivery significantly increased hemoglobin levels and improved iron stores and other hematological parameters at 4 weeks in a whole population. Basically, we are talking about improving the hemoglobin and improving the iron stores. The patient coming to you with a hemoglobin of 10 would still be complaining, a hemoglobin of 12 would still be complaining of fatigue, tiredness, and all those other symptoms of lack of concentration and all those symptoms of anemia with those who have low ferritin levels. But as soon as you improve their ferritin levels, although the hemoglobin change is not yet seen, but the patient symptomatology improves a lot. This is what our experience tells, and this is what the evidence also says. Then there was another study where FCM efficiently and safely and quickly corrects moderate to severe anemia in Indian patients in a short span of 4 weeks. So you can have good results in 4 weeks' time. There was a pilot study done in February 21 and published in International Journal of Reproduction, Contraception, Obs and Gynae. So it says that FCM is well tolerated and has the ability to transfuse in single high dose. And this makes it a preferred drug for faster and higher replenishment of iron stores and correction of anemia, and not only in pregnancy, but also in the postpartum period. Efficacy, when you compare it to the, you see this, I've been using FCM for the last 7 to 8 years. And before that, and while I was getting trained, we used to have IV iron in the form of ferric maltose, ferrous maltose. So sucrose. So it was very, frequently used. We used to give 5 doses, 3 days apart, and sorry, I can't hear? All right. All right. And we used to give 5 doses, 3 days apart, and the patient would be coming and going and coming and going, very inconvenient for them. But the results were there, and we had very few side effects with that as well. But then came ferric maltose, carboxymaltose, and this changed the game because it was just 1 dose, too short, 1 dose, and that's it for the patient. And you will see the change in 2 weeks' time, although the maximum change would be in 4 weeks, but you start seeing the change in 2 weeks. If you check the bloods, in 2 weeks, at least the serum ferritin stores would be high, and hemoglobin also starts increasing, but you will see the maximum effect in 4 weeks' time. Now, there are studies that compare both. So the thing is that FCM, according to the studies, they say that it improves the level much quicker, and the effect stays for longer as well because you're increasing the ferritin stores as well. So those ferritin, the iron stores are then used to make more hemoglobin and avoid the anemia. Multiple studies have compared this. So intravenous FCM is better and safe than those studies have indicated that FCM is better than IS, and it has advantage of administrating a large dose is in single setting, and especially during the second and third trimester. So the same thing again. This is the study that was in the drugs real world outcome journal, and this effect of ferric carboxymaltose versus low dose intravenous iron therapy and iron sucrose. So they said that FCM has significantly lower monthly total healthcare cost versus patients receiving low dose intravenous iron or iron sucrose in the 12 months following IV iron treatment. All right. So when you compare the total cost of this with the other two, the FCM is more cost effective. Another study done in India where they compared the safety and efficacy of IV iron sucrose and ferric carboxymaltose in the treatment of postpartum iron deficiency anemia. And they have the same views that it is more effective than IV iron sucrose for the correction of postpartum iron deficiency anemia. Again, another study, this was done in Pakistan, and they say that it is superior to intravenous iron sucrose with respect to hematological response, which seems to be safe as very few severe side effects were observed. And another study comparing the two and showing the same results, the better results here. So basically, It is the drug of choice in iron deficiency anemia during pregnancy and the postpartum anemia. And the comparison of a rise in the hemoglobin in 6 weeks, iron sucrose is 1.8, whereas ferric carboxymaltose is 2.6 gram percent. And the ferritin stores are 82.4 gram. They reached this level, while with the ferric carboxymaltose at 6 weeks, it reaches 100.9 grams. In the postpartum period, again, the iron sucrose will increase the hemoglobin by 22%, while FCM will increase it 52, more than double the range. Superior efficacy than oral. And then if you compare it, the other form of treatment is blood transfusion. So blood transfusions are definitely needed in cases of emergency, in case when you are about to operate on a patient and the hemoglobin is low, or if she's about to deliver, the hemoglobin is low. And if you have to improve her HP, not only for just the pregnancy and growth of the fetus, but supposing if you have to pass the morbidly adherent placentas. So in those cases, you need to have a good HP, and for that you need blood transfusions, which will increase the HP in very short period of time. But cases where you have time to improve the HP over, say, 3 to 4 weeks, FCM would be preferred. So if HP is 7, less than 7, so erythrocyte maturation takes 10 days. So you need time for FCM to work. Treat iron deficiency anemia it treats by replenishing the iron stores as well. It's not just the hemoglobin, the ferritin as well. There is no risk. Administration occurs in 30 minutes, and there's no need of donor. This is another one point for blood transfusion. You need to have donors as well. Blood transfusion when HB is less than 7 gram and there's urgency, but it doesn't replenish the iron stores. It will just correct the anemia and that's it. And administration time is about 2 to 4 hours. So this is how you compare. And the other thing is with blood transfusion, obviously there is always a risk of infections, the viral infections, especially the hepatitis B, C, and the HIV and other STDs can be transferred. And the other thing is that with multiple blood transfusions, truly the transfusion related acute lung injury can also occur because of that thing. So one has to be very careful with the blood transfusion. And if you have a better and safer option, why not go for it? So how does ferric carboxymaltose work? It's a non-dextran macromolecular iron complex consisting of a ferric hydroxide core, and it is stabilized by a carbohydrate shell. So inside is the hydroxide, and ferric hydroxide and carbohydrate is on the outside. Mechanism of action is that there's controlled delivery of iron to the target tissues. There's minimal release of free iron during administration, and there's efficient utilization via the reticuloendothelial system, and it is incorporated into erythroid precursors for hemoglobin synthesis. Administration is like IV infusion or bolus injection with no test doses required. Distribution is about half-life is 7 to 12 hours with minimal renal elimination. And metabolism processed in a reticuloendothelial system, iron incorporated into ferritin. A simplified dose is, you can calculate the exact dose according to Genzoni's formula, where the required amount would be weight of the patient multiplied by the difference of the actual and the target and the actual hemoglobin, the difference multiplied by weight multiplied by 2.4, and then you add the iron stores to it. So you'll get a figure, and that's what you are required to give to the patient. But to make it simple, if it is less than 10 gram percent, 1500 milligram totally is needed. If it is more than 10, between 10 and 11, 10 and 12, so 100 milligram is needed. Practically what you do is that there is pre-administration, you confirm the iron deficiency, you calculate the dose, and you review the contraindications. The contraindications are basically if there is a known allergy to the to iron, maybe oral or whatever form, or there is history of allergic diseases in the patient. These are the just two contraindications to it. Otherwise, all other women can receive ferric carboxymaltose very safely, and we've been using it. Administration is that 2 vials, which is 1000 milligram, is diluted in 200 ml and given over a period of 15 minutes. This is recommended by the manufacturer. But in my experience, and what we do is that we use 2 vials in 500 ml and we transfuse it over a period of 45 minutes to 1 hour. And patients are perfectly fine. In the initially when I started using it, so I would give it in 250, and some of the patients would complain of giddiness and palpitations. But once we started using it in a more dilute form in 500 ml, those symptoms were gone and the patients were fine. They say that you can give it as a bolus at a rate of 1 ml per minute, and no test dose is required. No test dose is required, but initially for the first 5 minutes, we give it at a very slow rate for about 15 drops per minute. And then after the 5 minutes, if the patient is fine, then we increase it to 75 drops per minute, and it finishes in about 45 minutes to 1 hour's time. Post administration, obviously, you ask her to lie down for a bit, and you keep monitoring the hemodynamic status, and check HB after 2 to 4 hours, and not just the HB, but the ferritin and the transferrin levels at 8 to 12 weeks as well. So this is what you do with the patient, and it's very cost effective for the healthcare resources as well. Despite higher acquisition cost, right, to oral iron, if you compare to that, so they have to pay for it. But FCM demonstrates cost effectiveness through 74% reduced hospital visits, 33% reduction in transfusion requirements, 56% improved workforce productivity, and reduced absenteeism. Fewer adverse events requiring management. In pregnancy, second trimester, when iron falls, so consider FCM. It is safe and effective and is minimally transferred through the placenta. In the preoperative period, if the patient is going for surgery, whether gynecological, obstetrical, or otherwise as well, administer 2 to 4 weeks before elective surgery to optimize hemoglobin and reduce transfusion risk. As you mentioned, transfusion has their own bag of problems. This headache, nausea, hypophosphatemia, dizziness, this is seen if you give it at a faster rate. Other considerations are very few. Hypersensitivity reaction, especially in those patients who are allergic to iron, or they have other allergic diseases like eczema or maybe asthma. Skin discoloration at injection site, yes, this does happen. But for that, what we do is that it basically occurs when you are taking the cannula out and there is spillage of few drops at the site of the cannula, at the site of the prick, and those few drops then leave the discoloration, and it takes a while to recover. But what we do is that when that iron infusion is finished, we give the patient about 10 ml of normal saline. We flush that 10 ml of normal saline through the cannula and push the FCM high up so that when the cannula is taken out, there is no spillage of FCM. No iron is spilled there. Management strategy is same, that you monitor for 30 minutes and that's all. Overall safety profile compares favorably to other IV iron preparations. Chances of anaphylactic reaction, that can happen even with paracetamol, that can happen with Brufen as well, which is very commonly used, and it has the lowest at 0.8 cases per 10,000 doses. So you can see that. It was published in BMJ. So it has the lowest of the rate, the anaphylactic reaction to IV iron, and very safe. It can be used very safely. So this is Farkari. You all must have seen the it outside this room, this hall. and I'll take your questions if there are any questions, any suggestions, any sharing the experiences, anything. You're most
Thank you, Professor Sidra Khan, for your very interesting and comprehensive talk. As we're going to do the Q&A section only after the third speaker, may I request you to take a seat here? Thank you for your very, comprehensive talk. Okay. Yes, please. Could you come and take a seat here? As I've said, we're going to do the Q&A section only after the third speaker, and shall we move to the second topic. The second topic is going to be iron deficiency and anemia in heart failure and chronic kidney disease. As you all know, in our medical practice, those two organ failures are very, very common to see. And then, luckily, when we went to European Society of Cardiology in 2023 and 2024, we highlighted the iron therapy, especially parenteral iron therapy in terms of ferric carboxy dose therapy in patients with heart failure. It can reduce the number of hospitalization. It increases the functional status of the patients and quality of life. And then finally, it becomes a +1A recommendation in ESC guidelines. Another organ failure is what we've seen in daily clinical practice as chronic kidney diseases. And oral iron therapy has been given to many patients with chronic kidney diseases. Some of the patients, they can't tolerate the iron therapy. In such case, especially patients with the hemodialysis, they will need parenteral iron therapy. Those two topics will be talked by the Professor Hey Azaan. May I introduce very briefly, as you all know, Professor Hey Azaan is a well-known physician as well as well-known speakers, currently working as a professor of medicine in University of Medicine 2, Norfolk General Hospital, as well as clinical director of medicines. May I now invite Professor Hey Azaan to talk to the topic, anemia and iron deficiency in heart failure and CKD. Shall we welcome Professor Hey Azaan, please?
Thank you very much, Mr. Chairpersons, all the distinguished guests, and then speakers as well, especially those coming from the Pakistan. I'm really honored to have a part of this very lovely symposium as well. Because the clock is ticking and the time is running short, I'll start straight away with my topics, and let me use bilingual language, my presentation. So as Chairperson Professor Zolian mentioned that we all have to face cases like the heart failure and renal failure day by day. It's very common in our clinical practice. So the first thing we have to know is that what about the definition of the heart failure? It's nothing but it's a syndrome, clinical syndrome, with symptoms and signs caused by a structural and or functional cardiac abnormality. You can test NT-proBNP. And or objective evidence of pulmonary and systemic congestion so that you can define whether this patient might have the heart failure without doing NT-proBNP level to diagnose the patient as having the heart failure. 2021 ESC guideline မှာ diagnostic algorithm ရှိတယ်သူတို့ကတော့ anti-proBNP ကို skip မလုပ်ဘူးပေါ့နော် we can skip that step. After that we have to request for the echocardiogram to categorize the heart failure into 3 categories. The first one is the heart failure with a reduced ejection fraction. It's about ejection fraction is less than 40%. If it is 41 and 49, we label the case as the mid-range EF, and if it is more than 50, we define that person as having the heart failure with the preserved ejection fraction. အဲ့တော့2024မှာ ESC အသစ်ထွက်တယ်။ဘာတွေများအသစ်ပါလဲဆိုတော့ heart failure မှာသူက comorbidities တွေကိုဦးစားပေးပြီးတော့ပို့ပြောလာတယ်။ especially obesity. ဆရာကိုတို့ဒါမကြပြောနေ heart failure with obesity, booming and looming subject as well. And then CKD and diabetes ကျွန်တော်တို့ဒါဂရုစိုက်ပြီးကြည့်ရတော့မယ် So also is the iron deficiency and heart failure as well. It's very important topic in near future. So heart failure နဲ့ပတ်သက်ရင်ကျွန်တော်တို့မှာပြေးစရာ treatment က we have a fantastic four strategy. ဘာတွေလဲဆိုတော့ RNE ဆိုတဲ့ဟာပါတယ်ပေါ့နော် Sacubitril plus valsartan ဒါပြီးတယ် beta blocker ကျွန်တော်တို့ပြီးတယ် MRA ပြီးတယ် SGLT2I inhibitor ပြီးတယ် four drugs within 4 weeks ကို titrate ကျွန်တော်တို့လုပ်ကြရတယ် prognosis ကောင်းတယ် benefits တွေကောင်းတယ်ဘယ်လောက်ထိတော့ကောင်းလဲဆိုတော့ conventional therapy နဲ့ရှင်လိုက်လို့ရှင်ခုန four drugs within 4 weeks ပေးလိုက်ခြင်းအပြင် CV death and heart failure hospitalization 62% ကြတယ် CV death တွေ 50% အောင်ကြတယ် hospitalization 68% ကြတယ် all cause mortality 47% ကြတယ်ဆိုတော့ overall အနေနဲ့ 44% လောက်ထိဒီ four drugs ကရနိုင်တယ်သို့တော်လည်းပဲ substantial residual risk ရှိနေသေးတယ်ကျွန်တော်တို့ဒီ four pillars ပေးတာတော့မှာပဲအဲ့ဒီအတွက် we need another superman in our management in the of the congestive cardiac failure it's nothing but the Verasequat နော်နည်းနည်းတော့ကျွန်တော်တို့မြန်မာလူမျိုးအနေနဲ့တော့နာမည်ကမှတ်ခက်တယ် Sequat ပဲမှတ်ထားရတော့နော် Verasequat ဆိုအဲ့တော့ရပြီလားလို့မေးရင်တော့မရသေးဘူးသူများတိုင်းပြည်မှာလည်းတွင်တွင်ကြဲကြဲတော့သုံးသေးဘူးပေါ့နော်သူကဘာလုပ်လဲဆိုသူက level 3ခုကိုထိန်းတယ် heart မှာထိန်းတယ် blood vessels မှာထိန်းတယ် kidneys မှာထိန်းတယ် heart မှာ ventricular relaxation ကိုကောင်းစေတယ် ventricular filling ကိုကျစေတော့ load ကိုလျော့ပြီးတော့ fibrosis လျော့သွားတယ် coronary blood flow ကောင်းစေတယ် at the same time မှာ blood vessels level မှာ vasodilation ဖြစ်စေတယ် vascular distensibility ကိုတက်လာစေတယ် kidney level မှာ renal blood flow ကောင်းစေတယ် fibrosis ကိုလျော့စေတယ် renal protection ရတယ်ဆိုတော့သူတို့သုံးကြရတယ်ပေါ့နော်ဆိုတော့ since 2021 ESC မှာ 2B recommendation ပေးတယ် ACCH America ဘက်က 2B recommendation ပေးခဲ့တယ်2024 ESC မှာတော့ Verasequat reduced the composite outcome of CV death and fast heart failure rehospitalization in patients with reduced ejection fraction လို့ပြောတယ် it can significantly improve LV structure and function as well ဆိုတော့ကျွန်တော်တို့မှာ fit agent အနေနဲ့သုံးစရာ Verasequat ပေါ်လာတယ်ဆိုတော့ four pillars plus Verasequat is it enough ဆိုတော့ like in James Bond movie name the world is not enough နော်ကျွန်တော်တို့မတင်းတိမ်နိုင်ဘူး mortality တွေတက်နေတော့မယ်လူနာတွေရဲ့ quality of life ကိုကြည့်တော့မကောင်းနေသေးဘူး functional capacity တွေမကောင်းနေသေးဘူးအဲ့တော့ဘာများလို့မလဲလိုက်ကြည့်တော့ the sixth agent is the IV iron therapy ဆိုတာသူတို့သွားတွေ့တယ်ပေါ့နော်ဆိုတော့ anemia က as the previous speaker already mentioned in our slides as well according to the WHO မျိုးသားမှာ hemoglobin let's say 30 but women မှာ 12 outပေါ့နော်So what about the prevalence of anemia and heart failure, especially in patients with reduced ejection fraction? We have 30 to 50% of patients with heart failure with reduced ejection fraction have anemia, especially in elderly persons, advanced NYHA class, those with CKD. So it's not that uncommon.ကျွန်တော်တို့သတိထားရမယ့်ပြဿနာဖြစ်လာတယ် Pathophysiological process မှာအများကြီးရှိတယ် among them the most important and then reversible one is the iron deficiency ကျန်တာ inflammatory process ပါတယ်ပြောတယ် CRP တွေတက်တယ်ပြောတယ် how to tackle that CRP how to tackle that inflammatory process it's not that easy ကျွန်တော်တို့မှာလွယ်တာ iron deficiency ကို recognize လုပ်ပြီးပြင်နိုင်တယ်ပေါ့နော် renal dysfunction ရှိမရှိကြည့်ရမယ် and then nutritional deficiency as well rather than iron like the B12 folate ဒါတွေဟာပါတယ် and then drugs as well because most of the patients are on the ACEI and ARB they can suppress erythropoiesis it's less known fact and then they might be on the antiplatelets which might lead to substantial GI bleeding as well and then hemodilution process we also play a crucial role in the physiology of anemia and heart failure as well. So anemia ရှိတဲ့လူတစ်ယောက်ဘာတွေများဖြစ်မှာလဲ heart failure. The first one is the reduced functional capacity. အရေးကြီးပါတယ် daily life မှာကျွန်တော်တို့နောက်10နှစ်နေမှတည်ရတဲ့ဆိုင်ဒီနေ့မလှုပ်နိုင်တာပိုအရေးကြီးတယ်ဒီနေ့မောနေတာပိုအရေးကြီးတယ်ပေါ့နော် And then increased mortality and hospitalizations, poor quality of life, and NYHA class progression, anemia ရှိလေလေမြန်မြန်ဆိုးလေလေဆိုတာကိုသွားတွေ့တယ်ပေါ့ So how to diagnose? It's very simple. The first one, we need to identify the hemoglobin level by doing the complete blood count or complete blood picture. Second thing is we need to assess the iron stores, iron status by doing the ferritin and DSAT, transferrin saturation. အဲ့တော့ဒီနေရာတွေမှာ inflammatory process ကပါနေတယ်ဆိုတော့ကျွန်တော်တို့က ferritin is the marker of the inflammation as well, so that we can rely solely on the ferritin level in these sort of cases. That's why DSAT is more important to diagnose iron deficiency anemia in patients with heart failure as well as in CKD as well. တခြားဟာတွေကတော့ကျွန်တော်တို့ CRP inflammatory process စိတ်ဆိုးတဲ့ထင်ဖောက်ကြည့်မယ်ပေါ့ B12 folate clinical picture သိတူရင်ဖောက်မယ်ပေါ့လိုရင်ဖောက်မယ်လာသမျှ heart failure တိုင်းတော့ B12 folate ဖောက်ဖို့မလိုဘူးပေါ့ but creatinine and EGFR is very important ဘာကြောင့်လဲဆိုတော့ heart failure နဲ့ CKD ကလွန်တွဲပါတယ် strategy နည်းနည်းကွာပါတယ်ပေါ့နော်နောက်တစ်ခုကတော့ခုန antiplatelet ပေးထားတယ် loss လေးနည်းနည်းရှိနေတယ် bleed ရှိတယ် obvious bleed တော့မရှိဘူးဆိုရင် stool fit ပေါ့အခုခါမှာတော့ကျွန်တော်တို့လုပ်လို့ရတယ် stool for occult blood လုပ်လိုက်လို့ if it is positive ဆိုရင် we need to proceed and liaise with the gastroenterologist whether the patient might need colonoscopy to detect the source of the bleeding in his lower GI tracts နော်ဒါလေးတွေကျွန်တော်တို့ရှာဖို့လိုတယ်ပေါ့ also in the upper GI tracts as well. So iron deficiency and heart failure below identify low male. So the first thing is our serum ferritin. If it is less than 100 microgram per liter, we label that particular person as having the absolute iron deficiency. If it is 100 and 299, or let's say less than 300 microgram per liter and TSAT less than 20%, then we label that person as having the functional iron deficiency. Categorize low naima. So how to manage that sort of patients? The first step is to optimize the underlying heart failure by using the 4 medications within 4 weeks. And then at the same time, we have to correct the volume overload by giving the diuretics. And then we also need to assess the other comorbidities like the CKD, malnutrition, bleeding as well. The second step is the IV iron therapy, very strong evidence, Shiba.ဒီနေရာမှာ argue လုပ်နိုင်တာက why not oral iron therapy ဒီလို case တွေမှာဘာကြောင့်လဲဆိုတော့ heart failure ရဲ့ pathophysiological process မှာပြန်ကြည့်လိုက်လို့ရှိရင် hepcidin level က increase ဖြစ် hepcidin level တက်နေလို့ရှိရင် oral iron therapy ပေးလို့ရှိရင် absorption poor ဖြစ်တဲ့အတွက်ဒီလိုနေရာမှာမရအောင်ကျွန်တော်တို့က trials တွေနဲ့ parenteral iron therapy ပေးပြီး heart failures မှာလုပ်ထားတဲ့ studies တွေအများကြီးရှိတယ် starting from the 2009 up to 2023 fair heart failure trials, confirm heart failure trials, affirm acute heart failure trials, and then IMN trials. Fair heart failure 2009 မှာ IV သူဘာနဲ့စမ်းထားလဲဆိုတော့ဒီနေ့ကျွန်တော်တို့ပြောနေတဲ့ ferric carboxymaltose FCM လို့ပဲကျွန်တော်အတူကောက်ပြောပါမယ် Improve symptoms and quality of life in heart failure with reduced ejection fraction and iron deficiency. It was published in New England Journal of Medicine since 2009. So confirm heart failure 2015 ma 6-minute walking test ko improve phit se der, fatigue ko yaw ja se der, hospitalization ko reduce phit se der. So symptomatic improvement apien ko di heart failure patient တယောက်နောက်တစ်ခေါက်ဆေးရုံပြန်မတက်ရအောင်မှာကာကွယ်နိုင်တယ်ဆိုတာ 2015 confirm heart failure မှာထပ်ပြောလာနိုင် additional benefit နင် So what about acute heart failure 2020 post acute heart failure discharge မှာတဲ့ rehospitalizations ကိုကြာစီတယ်လို့သူကပြောတယ်ပေါ့နော် Ironman မှာတော့ long term outcomes ကိုတော့သူ improve ဖြစ်နိုင်တယ် especially CV events and death ကိုတော့ကြာစီတယ်ဆိုတော့ data လောက်ထိတော့ရောက်တယ်ဒါပေမဲ့အဲ့ဒါ debatable တော့ဖြစ်နေသေးတယ် sincerely and honestly speaking we need to look for further researches in the recent coming years လာမယ့်နှစ်ဒီမှာဘယ်လောက်ထပ်ထွက်လာအောင်မလဲတော့မူတည်သေးတယ် so mortality benefit ဘယ်လောက်အထိကောင်းပါလဲတော့ အခုချိန်မှာပြောရနည်းနည်းတော့ခက်နေသေးတယ်သို့တော်လည်းကျန်တဲ့အပိုင်းတွေ quality of life functional capacity rehospitalization ဒါတွေအတွက်ကတော့ very strong evidence to use the IV ferric carboxylate mild dose in patients with heart failure with reduced ejection fraction and iron deficiency anemia ဒါတော့ကျွန်တော်တို့ခိုင်ခိုင်မာမာပြောနိုင် so dose အနေနဲ့ကတော့ဒါ previously mentioned that 1000 milligrams usually heart failure မှာတော့ IV parenteral over 50 minutes ပေးလို့ရှိတယ် 4 to 6 weeks လောက်မှာကျွန်တော်တို့ reassess လုပ်တယ် what about the recommendations ESC 2024 က class 1A level A recommendation ရတယ်ဆိုတော့တော်တော်ခိုင်မာလာပြီပေါ့နော် American အုပ်စုကတော့ still သူတို့ကြည့်နေတော့မယ်ပေါ့နော်နောက်တစ်ခုကတော့ role of the oral iron not recommended လို့တော့သူကရေးထားတယ် poor absorption GI side effects တွေများတယ် studies တခုသူတို့ထုတ်နှုတ်ထားတယ် iron out heart failure trial JAMA မှာ2017လောက်မှာ publish လုပ်ထားတယ် oral iron ပေးထားတယ် no improvement in peak VO2 or functional status so what about the role of ESC နီးမြားရှိရင်ကျွန်တော်တို့ erythropoietic stimulating agents ပေးချင်ကြတယ်ပေါ့အခုသတိထားဖို့ကbone marrow stimulate မလုပ်ခင်မှာ we need to replenish the raw like the iron B12 and folic in the marrow before stimulating that iron by ESC ဆိုတော့သူ့ရဲ့ role ကဘယ်လောက်ရှိလဲ red heart failure trials New England Journal မှာပဲ2013မှာ publish လုပ်ထားတယ် W poitin နဲ့ဆန်းထားတယ် no reduction in death and hospitalization ပိုဆိုးတာက thromboembolic events တောင်ပိုများစေတယ်လို့ပြောတယ် so we need to be very careful in prescription of the erythropoietic stimulating agents in patients with heart failure do not use routinely လို့ပြောတဲ့ guideline ကဒါပေမဲ့ should consider only in severe anemia if the hemoglobin percentage is less than 9 if it is associated with CKD stage 4 and 5 yes we can use it and then after nephrology input we need to lace the nephrologists closely in these sort of patients so what about the role of blood transfusion anemia နဲ့ဘောက်ပဲနဲ့မောနေတယ်ပြီးကျင်တာပေါ့ not first line reserved for the hemoglobin level less than 7 မဖြစ်မှာပဲကျွန်တော်တို့ပေးမယ် if the patient is symptomatic in terms of angina very severe chest pain very dyspneic ဖြစ်နေတယ် and then in events like the acute bleeding GI bleed တွေရနေကျွန်တော်တို့ antiplatelet တွေပေးထားတယ် anticoagulation တွေပေးထားတယ် melina တွေရနေတယ်နော်ဒါဆိုရင်တော့ကျွန်တော်တို့ correct လုပ်မယ် with blood transfusion otherwise it's not a first line recommendation risk are of volume overload along the immunization infection and it can also increase the mortality of that particular heart failure patient as well so that we need to avoid the blood transfusion as far as possible special population in a studies they maပြောတာတော့ parenteral iron therapy has very strong evidence in heart failure with reduced ejection fraction and then mid-range ejection fraction တိတော့ပြောတယ် but with preserved ejection fraction မှာတော့ less evidence ပဲ studies တွေအများကြီးစောင့်ရအောင် CKD patients တွေ heart failure နဲ့တွဲရင် first line နေနဲ့ပြီးရမလားနောက်ပိုင်းမှာကျွန်တော်ဆက်ရှင်းပါမယ်အဲ့လိုလူမျိုးမှာ ESC ရဲ့ rule ပါလာ elderly patients တွေမှာ polypharmacy တွေကျွန်တော်တို့ exclude လုပ်ဖို့လိုတယ် we need to rule out malnutrition deficiencies တွေကို exclude လုပ်ပြီးမှပေးဖို့ကောင်းတယ် pregnancy postpartum issues ကတော့ကျွန်တော်ရဲ့ co-speakers တွေကရှင်းသွားတာပေါ့နော်ဆိုတော့သူဘယ်နေရာအထိရောက်လာပြီလဲ2021မှာတော့ကသူဒီ 2A level မှာပဲရှိတိတ်ဇန်းတင်ပြီးမပြောကြသေးဘူးဒါပေမဲ့နောက်ပိုင်းမှာခုနကျွန်တော်ပြောခဲ့တဲ့ AFAM တို့ Ironman တို့လာတဲ့အခါမှာ2023ကနေစပြီးတော့ class 1A recommendation တွေကိုရောက်သွားတဲ့အတွက်သူဒီတူတူတန်တန်စံနမူနာပြုသုံးရမဲ့ standard treatment guideline ထဲမှာပါသွားပြီလို့ကျွန်တော်တင်ပြချင်တာပေါ့နော်ဒါ European ဘက်ကပြောတာ American ဘက်ကပြောတာလဲ in patients with heart failure reduced ejection fraction ခုန 4 medications ကျွန်တော်တို့ပြောခဲ့တဲ့ 4 pillars plus vericiguat မရရင် parenteral တစ်ခုချင်းစီကို dose တိုးကြည့်မယ် vericiguat တိုးကြည့်မယ်IV iron therapy ဆိုတော့ America ဘက်ကလည်း evidence level ကို 1A မပြီးသေးပေမဲ့သူတို့ရဲ့ guideline တွေထဲမှာတော့ထည့်သွင်းပြီးသုံးနေတယ်ပေါ့နော်ဆိုတော့ first part ဖြစ်တဲ့ anemia heart failure ကို summarize ပြန်လုပ်လိုက်ရင် heart failure မှာ common ဖြစ်ပါတယ် reduced ejection fraction patients တွေမှာ30 to 50% လောက်ကျွန်တော်တို့တွေ့နိုင်တယ် diagnostic and treatment approach ကတော့ကျွန်တော်တို့တည်ချာတော့လုပ်ဖို့လိုအပ်တယ် iron အဲ့ဒီတွေကမှ treatable cause ဒီ iron deficiency ဒါကြောင့်မို့လို့ကျွန်တော်တို့က modifiable risk factor လည်းဖြစ်တဲ့အတွက် we need to rule out that iron deficiency in these patients treatment modalities နေနဲ့ဆိုရင်တော့ oral ကျွန်တော်တို့သိအသုံးမတည့်ဘူး erythropoietin တချို့နေရာမှာသုံးမယ် blood transfusion not a first line ဆိုတော့ parenteral iron therapy especially FCM improves quality of life of that patient increases functional capacity increases exercise tolerance and reduces rehospitalization rates so many randomized control trials are there and then oral iron and ESC therapy are not recommended in most heart failure cases. So heart failure နဲ့ပတ်သက်ပြီးတော့ management of anemia, especially iron deficiency anemia ကိုကျွန်တော် correct လုပ်ခဲ့တယ်ပေါ့နော် So second portion in anemia and CKD, it's also very common. ပြောရရင်ပိုတောင်တွေ့တယ်လို့ပဲ heart failure နဲ့ anemia တွေ့တာတဲ့ဆိုင် CKD နဲ့ anemia တွေ့တာတွေပိုများတယ် So what about the prevalence? Stage 3 လောက်ရောက်ပြီဆိုတာနဲ့ 10 to 20% of patients have anemia. Stage 4 to 5 ဆိုရင်တော့ more than 50%. ကိုယ်စရန်10ရောက်လာရင်9ရောက်လောက်ကတော့အနည်းဆုံး anemia ဖြစ်နေပြီပေါ့နော် And then it associated with the fatigue, cognitive dysfunction, လူသိနေတာ left ventricular hypertrophy, heart failure ပိုဖြစ်တယ် mortality ပိုဆိုးတယ်ဒါကြောင့်ကျွန်တော်တို့က CKD မှာ anemia ကိုကုပါလို့ပြောတာပေါ့နော် reduce quality of life Pathophysiological process ပြောရင်လည်းသူဒီလည်း it's also a multifactorial process ပါပဲ The first one ကတော့အရေးကြီးတာသူ့မှာ erythropoietin deficiency ပဲเนาะဆိုတော့ bone marrow ကနေပြီးတော့ဒါနည်းသွားပါเนาะ leads to inadequate bone marrow stimulation လျော့သွားလို့နှစ်ကတော့ iron deficiency လို့တော့မပြော iron homeostasis dysregulation iron store ကသူ့စီမှာပြေကောင်းပြေနေနိုင်တယ်ပိုတောင်ပိုရှမ်းနိုင်တယ်သို့တော်လည်းမသုံးနိုင်တာ iron homeostasis dysregulation လို့ပြောတယ် mechanism စီတော့အများကြီးပေါ့နော်ရှင်းထားတာတွေနောက်တစ်ခုကတော့ CKD patient တွေမှာ RBC lifespan က uremic toxins နဲ့ other oxidative stress တွေကြောင့်ပုံမှန်ရက်120ခံရမယ့်အစားသက်တမ်းပိုတိုသွားပါတယ်တဲ့ and then chronic inflammatory process play a significant role in the physiological process of anemia and CKD as well and then blood loss ဒါတော့ကျွန်တော်တို့ clinician များအနေနဲ့အထူးသတိပြုပွဲရာအထင်မှတ်ပဲနဲ့တရားခံကိုဖြစ်နေတယ်နေ့တိုင်း creatinine စစ်မယ်နေ့တိုင်း potassium လေးစစ်လိုက်ပါအောင်ဒီနေ့ urea များတက်သွားလားလူနာ confuse ဖြစ်လာ urea တက်လာပြီနေ့တိုင်းသွေးဖောက်နေတာအဲ့ဒါက one of the reason for causing anemia in that particular sort of patients ပေါ့နော် and the dialysis related losses တွေဖြစ်နိုင်တယ် GI bleeding occult GI bleeding obvious GI bleeding ကတော့လူတိုင်းသိတာပေါ့နော်So diagnostic evaluation is the same thing applied like in the iron deficiency anemia. The first thing we need to check the blood hemoglobin level and the second thing is the iron status. ကျန်တာတွေကတော့ခုနပြောခဲ့သလိုပဲအပိုရွယ်ပါလာတာက PTH CKD မှာ PTH ရဲ့ role ကပါတယ်ဒီနေရာမှာ high parathyroid hormone may suppress erythropoiesis အဲ့တော့ treatment strategies for anemia and CKD မှာ PTH ကိုကျွန်တော်တို့treat လုပ်ရမယ့် condition တခုလည်းပါလာတာပေါ့နော် interpretation နေနဲ့တော့နည်းနည်းကွာတာလေးတွေ့လိမ့်မယ် less than 100 it's okay T-set less than 20 it's okay ဒါပေမဲ့ ferritin ကိုကြည့်လိုက်လို့ရှိရင် heart failure တုန်းကကျွန်တော်တို့က300နဲ့ဖြတ်တယ်ဒီမှာတော့800လောက်နဲ့ဖြတ်တယ်ဘာကြောင့်လဲ CKD မှာ inflammatory process ပိုများတယ် role of inflammation ရှိတဲ့အတွက် ferritin is the one of the surrogate marker of the chronic inflammation so that ferritin might be increased in these sort of patients ဒါကြောင့်သူက800လောက်ထိတော့ extend လုပ်လိုက်တယ်ဒါပေမဲ့ key ကတော့ T-set ပဲ whatever it is if it is T-set is less than 20ဆိုရင်ကျွန်တော်တို့ဒါယူလို့ရတယ်ပေါ့နော်ဆိုတော့ management အနေနဲ့တော့ step 1က correct the reversible causes as well ခုနကျွန်တော်တို့ပြောခဲ့တဲ့ iron ကို deficient ဖြစ်တယ်ဆိုရင် replenish လုပ်ဖို့လိုတယ် without replenishing there might be very limited role of ESA, erythropoietin stimulating agents in these sort of patients. So also is the same. We need to look for the blood loss and treat accordingly, hyperparathyroidism, inflammation, infection as well. Step 2 are iron therapy. No? Indications are hemoglobin less than 11. CKD go manage low de kama, hemoglobin thick day in le prognosis ဆိုးတယ်ဆိုတဲ့ study ဆရာရှိအရန်ကြီးတက်အောင်လည်းလုပ်လို့မရဘူးပေါ့နော်ဆိုဘယ်လောက်ထိအကြခံပါလဲ lesson 11လောက်တော့ရောက်ပြီ T-set less than 30 and ferritin less than 500 CK ခုန heart failure နဲ့တော့နည်းနည်းလေးတော့ကွာတယ်ဒါက KD ကို2021ကိုကျွန်တော်ယူပြီးပြောတာနော်သူကအဲ့လောက်ဆိုရင်တော့ပေးသင့်တယ်ပေါ့လေဆိုတော့ oral ပေးမှာလား parenteral ပေးမှာလားကိုယ့်ရဲ့လူနာက dialysis လုပ်နေတာလား non dialysis လား dialysis လုပ်နေတဲ့ patient ဆိုရင်တော့ the first option is the parenteral iron parenteral မှာမှ ferric carboxymaltose and iron sucrose the first speaker she already mentioned the comparison between the ferric carboxymaltose and iron sucrose so we should better choose the ferric carboxymaltose in these sort of patients dialysis မလုပ်ဘူး hepcidin level လဲမြောက်မြောက်များများမတက်ဘူးထွင်ဆိုရင်တော့the first line agent should be oral iron ကျွန်တော်တို့ oral လေးပေးလို့ဆိုတယ်ပေးလို့ရတယ်ပေးရင်လည်းအလွန်ဈေးချိုတဲ့ ferrous sulfate နဲ့သူတို့ study တွေမှာလုပ်ကြပါတယ် the main reason ကတော့ problem ကတော့ GI upset ပဲ ferrous sulfate က GI upset တော့ဆိုးပါတယ်ပေါ့နော်အဲ့တော့ step 3အနေနဲ့တော့ iron ဖြည့်ပြီးပြီဆိုရင်တော့ erythrocyte stimulating agents တွေကိုကျွန်တော်တို့ပေးတယ် iron ဖြည့်ရတဲ့မှာ hemoglobin less than 10ရှိနေသေးတယ် or symptoms of anemia ရှိနေသေးတယ်ဆိုရင်တော့ we better need to avoid the transfusion မပေးခြင်းဘူးဒါမျိုးဆိုရင်တော့ကျွန်တော်တို့က ESA ရဲ့ rule ကပါလာတယ် ESA ပေးပြီးဘယ်လောက်ထိတင်ကြမှာလဲ not to exceed 11.5 gram per deciliter ဘာကြောင့်လဲဆိုတော့ publish လုပ်ထားတဲ့ trials တွေ research တွေအများကြီးရှိတယ်73ထက်တော့ဘယ်တော့မှရောက်အောင်မတင်ရအောင် CKD patient 73ထက်တင်လိုက်တာနဲ့ cardiovascular risk များတယ်เนาะဒီအောက်မှာပြောထားပါတယ်choir and treat trials က hemoglobin targets 13 14ရောက်သွားတာနဲ့အဲ့ဒီ CKD patient တွေမှာ stroke prevalence ပိုများတယ် hypertensive emergency urgency ပိုများတယ် myocardial infection နဲ့ infarction နဲ့ sudden cardiac death ဖြစ်တာပိုများတဲ့အတွက်73အထက်တော့ရောက်အောင်ကျွန်တော်တို့မတင်သင့်ဘူးသုံးနိုင်တာကျွန်တော်တို့မှာ e-poietin alpha darby poietin တခြား poietin တွေရှိတယ်ပေါ့နော် SC ပေးလို့ရတယ် IV ပေးလို့ရတယ် preparations ပေါ်မူတည်ပြီးတော့မှတစ်ပတ်ကို3ချိန်အထိပေးတာတွေရှိတယ်နှစ်ပတ်မှတစ်ချိန်လောက်ပေးတာရှိတယ်တစ်လမှတစ်ချိန်လောက်ပေးတာတွေရှိတယ်ပေါ့နော်ဆိုတော့we have ESA as well ရှိတယ်ပေါ့ step 4ကတော့ကျွန်တော်တို့စီမှာမပေါ်သေးဘူး literature စီထဲကြည့်လိုက်တော့မှတွေ့တာရှာလဲတော်တော်ခလုတ်တိုက်တယ် hypoxia inducible factor proline hydroxylase inhibitors HIF PHIS သူတို့ကဘာသွားလုပ်တာလဲဆိုတော့ stabilizes HIF နော်ဒီမှာ hypoxia inducible factor ကို stabilize လုပ်လိုက်ခြင်းအပြင်နဲ့ endogenous e-poietin ကိုပိုထွက်စေတယ်ခုန iron absorption ကိုသွားတားနေတဲ့ hepcidin level ကိုကျသွားစေတယ်ဒါကြောင့်မလို့ iron absorption from the gut ပိုကောင်းစေတယ် mobilization ခုနပြောတဲ့ iron တွေများပြီးသုံးမရတဲ့အခြေအနေကိုသူကပြင်ပေးနိုင်ဆေးနာမည်တွေကတော့မှတ်ရခက်တယ် Juiced နဲ့ဆုံးတယ် Roxadustat တို့ Debrojustat တို့ဒါ US မှာတော့သူတို့ FDA approve လုပ်ပြီး advantages ကတော့ oral ပေးလို့ရတယ် may reduce the need for parenteral iron therapy and ESC ကို short ချနိုင်တော့ဈေးလဲချိုမယ်ပါဇက်ကလည်းတိုက်လို့ရမယ်ဆိုရင်တော့ဒီကောင်တွေကနောက်ပိုင်းမှာတကယ် key player ဖြစ်လာနိုင်တယ်ပေါ့နော်ဆိုတော့စောင့်ကြည့်ဖို့တော့လို့တခါလေလဲပြောတိုင်းဖြစ်မလာတဲ့ strategy တွေလည်းအများကြီးရှိတာပေါ့အဲ့တော့ practice guideline summary ကတော့ KD ကိုပဲကြည်ကြည် nice UK ဘက်ကဟာပဲကြည်ကြည်ကျွန်တော်တို့ European Renal Association 2013ပဲကြည်ကြည် target ကတော့သူတို့က10နဲ့ 11.5 လောက်ရောက်ရင်ကျင့်တတ်တယ် iron targets မှာတော့ ferritin less than 500 T-set less than 30% ဆိုရင်တော့ parenteral iron therapy ပေးကြမယ်ဟေ့ဆိုပြီးတော့ပြောတယ်ပေါ့နော်ဆိုတော့ risk ကိုရှိသလား risk and benefit ရှိတာပေါ့ကျွန်တော်တို့ဒါ how to monitor ပေးထားပြီးရင် hemoglobin level ကိုတော့တစ်လားတစ်ချိန်လောက်စစ်တင်တယ်ပြောတယ် and then ferritin နဲ့ T-set ကတော့ every 1 to 3 months အနည်းဆုံးတစ်လ stable ဖြစ်ရင်တော့3လမှတစ်ချိန်လောက်စစ်တင်တယ် blood pressure အထူးသဖြင့် erythropoietin stimulating agents ပေးတော့မယ်ဆိုရင် blood pressure တိုင်းဖို့လိုပါတယ် it can shoot up the blood pressure and then lead the patient to have a hypertensive emergency and urgency and sinister consequences CRP might be required as PRN basis and then all the adverse effects must be monitored regularly ဆိုတော့မှတ်မိအောင်ကျွန်တော် case based clinical application လေးနဲ့ပြောပါမယ်เนาะအချိန်ကလည်း26မိနစ်ဆိုတော့ကျွန်တော်မိနစ်30ပြည့်ကန်ပြီးပါပြီဆိုတော့55နှစ်အမျိုးသား stage 4 CKD hemoglobin 9.2 ferritin 230ဆိုတော့ guideline နဲ့ဝင်သွားပြီ TSAT 18 okay CRP mildly raised symptoms က fatigue dyspnea and exertion so how to manage this patient are you going to going to give the epoetin first or parenteral iron therapy first or blood transfusion? Step by step management. The first step is we need to replenish the iron. Rapid replenishment low nine will be benefit yamo. So for rapid replenishment, we'll give the parenteral IV iron ferric carboxymal dose, let's say 1,000 milligrams. And then recheck hemoglobin and TSAT in 4 weeks. If hemoglobin is still less than 10, and then TSAT got 20 jodwabi, means iron deficiency but patient is still anemic. So we have to start the ESA. You can use any poitins, gabapentin method, epoetin method, and then we need to monitor and then adjust ESA dose to maintain hemoglobin 10 to 11.5, not more than 13. The message level take home message in a PI. Iron deficiency is common. What about in heart failure with reduced ejection fraction? It's about 50%. And then in CKD stage 3 and 5, more than 50%, let's say 60% of the patients will have the iron deficiency anemia. Diagnostic workup ferritin and TSAT is very important. And then indication for IV ferric carboxymal dose, symptomatic heart failure with reduced ejection fraction and iron deficiency, it's a class 1A recommendation. But from the point of view, from CKD point of view, 1A တော့သူမရသေးဘူး 2A အဆင့်မှာတော့သူဒီရှိနေပြီ and then benefits of IV FCM in heart failure with or without CKD မှာရှေ့မှာပြခဲ့တဲ့ကျွန်တော်ပြခဲ့တဲ့ evidence trials တွေအရ fair confirm NYH ကိုမြန်မြန်ပြန်တက်လာစေတယ် means ပိုကောင်းလာစေတယ်ပေါ့နော် exercise capacity ကိုကောင်းစေတယ် quality of life ကိုကောင်းစေတယ် heart failure rehospitalization ကိုကြားစေဘာကြောင့်ကျွန်တော်တို့က rehospitalization ပြောလဲဆိုတော့ patient တယောက်က heart failure patient တယောက်ကတစ်ခေါက်ပြင်ဆေးရုံပြန်တက်တိုင်းသူ့ရဲ့ baseline ကိုပြန်မရောက်တော့ဖြည်းဖြည်းချင်း decline ဖြစ်သွားတယ်တစ်ခါဆေးရုံတက်တယ်မူရင်းမရောက်တော့နောက်တစ်ခေါက်ဆေးရုံတက်တယ်မူရင်းနေရာပြန်မရောက်တော့ဒီလိုနည်းနဲ့ဖြည်းဖြည်းချင်းဆုံးတဲ့အတွက် we need to prevent that rehospitalization and then CV events နဲ့ death တွေကိုလျော့ကျစေတယ်ဆိုတဲ့ trials တွေလည်းထွက်နေပြီဒါပေမဲ့စောင့်ကြည့်ရအောင်မယ်ကျင်းတွေတော့ကျွန်တော်တို့မပြောနိုင်သေးဘူး CKD ဘက်ကကြည့်ရင်တော့ခုနပြောတဲ့ ESA requirements ကိုသူသဖြင့် short ချပေးနိုင်တယ် first step အနေနဲ့ iron deficiency ရှိရင် iron ကိုကျွန်တော်တို့ replenish လုပ်ဖို့လိုတယ်ဆိုတဲ့အကြောင်းပြောကြားခြင်းပါတယ်ဒါတွေကတော့ကျွန်တော်ရဲ့ဒီခုနပြောခဲ့တဲ့ section မှာသုံးခဲ့တဲ့ references များဖြစ်ပါတယ်အားလုံးကျေးဇူးအထူးပဲတင်ပါတယ် thank you so much
Thank you very much, Professor Heyayata, for your brilliant presentation view on anemia and iron deficiency in heart failure and CKD. Would you like to join us on this chair table? May I call upon another distinguished speaker, Professor Myo Nyinyi. He is a professor and department head of the University of Medicine, Magwe. He will be sharing his view on the update management of IDA in pregnancy and expert opinion. Professor Myo Nyinyi.
Good afternoon. First of all, I would like to express my gratitude to my all professors and distinguished guests, guest speakers, and my senior and junior colleagues. Today, the topic I would like to share our knowledge is uptake management on the iron deficiency anemia in pregnancy. I think that this topic is so familiar with all the clinicians. And this is based on the evaluation by the healthcare providers of Sankaini from the different regions of the India in 2024. This evaluation based on the current guideline research paper and integrated with their own clinical experience, because a clinical social demographic characteristic of the iron deficiency pregnant women are so familiar and not too different between with our country. So I would like to share the knowledge of uptake management of the iron deficiency anemia and some expert opinion today lunchtime talk. Let me start with the anemia and pregnancy. Currently, it is recognized as a major global health problem and affecting nearly half of all pregnant women worldwide. And globally, the most important pathological cause of anemia in pregnancy is iron deficiency. And WHO has previously estimated the global burden of deaths attributed to anemia. Approximately 20% of the maternal death is related to the iron-related consequences. And it also adds additional risk factors for the 50% of the all maternal death. Globally, 52% of the pregnant women from the undeveloped and developing countries are anemic compared with the 20% from the industrialized nation. According to the results reported in 2016, the global prevalence of the anemia was 32% in the non-pregnant and 40% in the pregnant women, the highest prevalence in Southeast Asia. According to the analysis of the prevalence of anemia, the higher prevalence of anemia in non-pregnant women seen in Yemen, Pakistan, and India. In pregnant women, the prevalence was high in the Yemen, Cambodia, and Myanmar, 53%. So let's go to iron deficiency anemia. Iron deficiency is the most common cause of anemia in pregnancy, and it requires effective treatment to prevent the severe consequences. But at WHO, despite its high prevalence, there is no standard definition of anemia during pregnancy. WHO defines less than 11 grams per cent, hematocrit less than 33 at any point during pregnancy. CDC and ACOG propose a trimester-based definition, less than 11 grams per cent, hematocrit at level 33 during the first and third trimester, and less than 10.5 and less than 32% hematocrit during second trimester. British Society of the Hematology define anemia in pregnancy as a hemoglobin less than 11 grams per cent in the first trimester and less than 10.5 in the second and third trimester, less than 10 in postpartum. What experts says the increasing prevalence of the IND among the pregnant women is accepted. Approximately 5 to 6 out of every 10 individuals showing symptoms or presently asymptomatic. According to the WHO criteria, nearly 50 to 70% of the individuals are anemic, with about 30% having level below the 8 to 9 grams per cent and often attributed to factors such as vomiting and malabsorption. So over 50% of the pregnant women affected moderate to severe anemia is observed in approximately 20% of the cases, predominantly in the third trimester. Subclinical anemia are widespread and affecting nearly 80 to 90% of the individual. In rural area, it's frequently report high prevalence rate and sometimes exceeding the 70% compared to the rural area, 20 to 30% middle class patient. So I would like to show the same prevalence study in our setting. Dr. came more on and studying the prevalence of INDA and hemoglobinopathies among the 500 pregnant women in Ulin General Hospital. It showed that overall prevalence anemia was 64 and nearly 22% were iron deficiency anemia. And another study of the situation of anemia among the pregnant women in Leeway Township in Imomo Luin found that 76% were anemic, among them the 60% had the low serum ferritin level. And findings from this study highlighted the situations of anemia associated factors among the pregnant women for the taking action to improve the knowledge and nutritional status. Another study is in Central Women Hospital. In one study, Kim Tin Wu found in the prevalence of anemia in this study was 55.67%. And it showed they saw that the pregnant women with a good knowledge, positive attitude, and good practice were less likely to develop anemia. Another study in Central Women Hospital in Myanmar were found in the among the 200 patients were observed to detect the hemoglobin level. It was found that 57 patients had anemia and 19.5 had iron deficiency. It's a little bit very difficult to find out the published data after 2020-21. And nearby country, Malaysia, the prevalence of anemia is around about 30 to 33% in this study, shown in this study. And another study in Myanmar, Azio and colleagues studied the prevalence of anemia and risk factors among the lactating mother in Myanmar from the Department of Social Medicine and Health Education, School of Public Health, Peking University, 2018. Hemoglobin and anthropometric indicators were measured in among the lactating women in 3 villages in Kachin and Shan State. They found that prevalence of anemia was 60.3% in lactating women, with a 20% having the severe anemia. Factors of the malnutrition, self-reported symptoms of the night blindness and poor adaptation, lack of the primary education, and low family annual capital income, and drinking the spring river water, drinking unboiled water, they all contributed. Risk factor. We already know that there are these risk factors contribute to iron deficiency and iron deficiency anemia, like chronic blood loss from the GI genitourinary system may reduce iron absorption from GI tract, decrease iron intake, increase demand like pregnancy and lactation. During pregnancy, risk factors like a previous anemic patient, multipurity, recent history of bleeding, conceived like someone year following delivery all contribute. So what experts said, a significant challenge in treatment compliance during pregnant women, among the pregnant women, is challenging to stick to the iron therapy due to busy schedules, and they are detailed by the side effects like GI issue and constipation. During the first trimester of pregnancy, nausea, vomiting, and GI bleeding as contribute iron deficiency anemia. Prevalence of the worm infestation. So all pregnant women should receive deworming treatment after 24-week gestation. Regarding the symptoms of anemia in pregnant women may vary from the typical presentation, potentially influencing for diagnosis and treatment. Clinical manifestation regarding a maternity. To maintain the iron sufficient state, it is critical to protect the health of the mother as well as to improve the pregnancy outcome and the foster-fetal development. In mother, iron deficiency is a state of the negative iron valence. And when the hemoglobin synthesis having limited by the lack of the iron and the person become anemic. Iron deficiency proceeds through the multiple non-anemic stages, and then body attempt to maintain the iron delivery to the red cells and non-heme tissue, including the brain. So there are many studies, submitted reviews, and they demonstrated that iron deficiency in the first and second trimester related to the increased risk of the adverse pregnancy outcome, and iron therapy during this period reduce the rate of these morbidities. Symptoms and signs of anemia. One, the symptoms and signs of anemia develop symptoms you already know that. And iron deficiency is associated with the increased risk of antenatal, intrapartum, and postnatal. You've seen in this slide. Iron deficiency, anemia, placenta atrophy, abnormal thyroid function, and preterm labor, as well as placenta abrasion, PE, eclampsia, risks of the operated delivery. In addition, increased risk of the postpartum depression, reduced quality of life as severe postpartum hemorrhage, and as well the need for the blood transfusion, postnatal maternal sepsis, or high risks. Fetal morbidity includes altered brain metabolism, neurotransmission, epigenetics, and myelination in offspring that passes into later in life. So in fetal life, increased risks of the adverse consequences, low birth weight, small SGR, preterm, increased fetal neonatal mortality as well. Additionally, offsprings are increased risks of the neurological disorder like autism spectrum disorder, attention deficit disorder, other intellectual disability. In 2019, this recent study showed that there is a significant association between the diagnosis of anemia prior to 30 weeks of autism spectrum disorder. Moderate to severe iron deficiency during antenatal and intrapartum period, it leads to the significant short and long-term consequences in the fetus. Immediate risks, fetal brain development, second risks, long-term brain development, third risks lead to the attendant neurodevelopmental sequelae, slower speed of processing, poor motor function, increased social dysfunction, etc. Postpartum period. During postpartum period, it also related to the postpartum depression, reduced quality of life, severe postpartum hemorrhage, and antenatal and postnatal maternal sepsis and need for blood transfusion, poor wound healing and cardiac failure, even maternal death, poor maternal infant behavioral interactions, and impaired lactation. So this two studies show that during the postpartum period, iron deficiency is a strong association between the maternal iron status and depression, stress, and cognitive function in the postpartum period. And during postpartum period, iron replenishment, single dose iron therapy also associated with a significant reduction in the physical fatigue, improved physical performance, and quality of life. Diagnosis. These we already know that we start with a hemoglobin complete blood picture. This level show that ratio reference value of the INDA, hemoglobin, hematocrit, serum ferritin, transferrin saturation, TIMBC, and soluble transferrin receptors. Traditionally, measurement of the hemoglobin concentration has been used to screen for the iron status. But anemia is the unstaged result of the negative iron valence, and hemoglobin concentration lack the sensitivity to detect the early stages because anemia, other than the iron deficiencies, are present. And so reliance on the hemoglobin concentration alone lack a sufficient sensitivity and specificity that we already know that. So we perform the other biomarker tests for other biomarkers like serum ferritin, TIMBC, percentage saturation of the transferrin and hepcidin. Serum ferritin concentration reflect the body storage iron, and clinically the findings of the low serum ferritin concentration highly diagnosed for iron deficiency. So serum ferritin is available, should be used in conjunction with the hemoglobin concentration. Percentage saturation of the transferrin is computed by this formula. Percentage of iron binding site reflect the percentage of iron binding site on the serum iron transport protein. Serum iron concentration decrease early during negative iron valence and thereby decreasing the percentage saturation. So measurement of this percentage saturation has confirmed the tenacious iron status pre-anemic woman. So as well, reticulocyte hemoglobin concentration also identifying the pre-anemia, pre-microcytic iron deficiency as well. In the future, measurement of the serum hepcidin concentration may provide the most information about who should or who should not receive the iron supplementation. It's a regulator of the intestinal iron absorption and iron distribution from the REC. It is synthesized by the liver in response to the iron status inflammation. It is negative regulated, and the high concentration reduce the intestinal iron absorption, and low level increase the intestinal iron absorption, and low level of the percentage transferrin found in iron deficiency and suppress hepcidin. This flowchart show that we first take hemoglobin and complete blood pressure and then iron steroid and to diagnose IDA with using the iron steroids. So what experts say? The need for basic blood tests, including hemoglobin, at the first patient visit. When anemia persists, performing the complete blood pressure is essential for the comprehensive understanding of the patient condition. Moreover, standard diagnostic tests that should be include hemoglobin, hematocrit, serum ferritin level. Ferritin level, although checked occasionally, they are critical for assessing iron stores and determining the extent of ID. Diagnosis of IDA involve the 4 primary groups of tests, and the evaluation begins with assessing the RBC parameters and indices. Direct measurement of the iron stores is conducted, which include analyzing the serum iron level to the iron binding capacity, percentage saturations and serum ferritin, and in some cases, bone marrow biopsy. The flow chart show that their opinion, the expert opinion, if the hemoglobin MCV is reduced and serum ferritin level equal less than 13 nanogram per ml, and increased TIMBC, low serum iron level, and low serum ferritin, this IDA. And serum ferritin 31 to 99 nanogram per ml with decreased TIMBC, high serum iron level, and high transferrin saturation, it is anemia other than the IDA. We need to investigate other alternative cause of anemia. Dietary intervention. We should start with the, we should also emphasize on the nutrition as well. Iron-rich nutrition involves the consuming foods that are good source of iron. Heme iron from the animals and non-heme iron from the plant base of meat, fish, poultry, and grain, nuts, seeds, beans, vegetables rich in non-heme iron. And food, some foods that block the absorption, like the milk, cheese, soy tofu, the chocolate, ice cream, etc. To raise the hemoglobin within a week, eat foods like beans, rice, raisins, or fortified cereals, consume vitamin C, like citrus and tomatoes, avoid drinking tea and coffee with meats. It is better absorbed iron when it has been fasting for about 8 hours. Iron supplementation. We usually start with the older iron, and patient with a mild anemia, hemoglobin 9 to 10.5, should start with the older iron, elementary iron, and daily. If the hemoglobin less than 10 during first and second trimester, we usually start older iron and increase the hemoglobin level 1 gram per cent after 14 days of therapy. There's to calculate the iron formula of requirements. Or what is possible? If the hemoglobin less than 10 during the first and second trimester, start with the older iron. If hemoglobin persists between 8 to 9 gram per cent, beyond 26 to 28, maybe reduce absorption and tolerance to oral. So recommend switch to parenteral therapy at third trimester. Dosage for normal pregnancy, 100 milligram per day, and for anemic patient, 200 milligram elementary iron, 2 to 3 divided dose. And there are some side effects, so GI side effects, as we already know that. Some preparation to gluconate, fumarate, and sulfate and citrate. And to maximize the absorption, it is better take fasting for about 8 hours or 2 hours before taking some other medications. Parenteral. Parenteral iron demonstrate faster hemoglobin hematologic recovery. Parenteral iron indicated if the response to oral therapy is inadequate, administered in the second and third trimester in patients who have moderate to severe anemia, and appropriate choice for before major surgery. Generally safe and associated with the fewest adverse effect, but some, although anaphylactic reaction is also considered. During an infusion of the for 30 minutes afterwards, the monitoring required for signs of hypersensitivity. Some adverse effects like hypotension, nausea, vomiting, arthralgia, abdominal pain. And we need to recheck hemoglobin full blood count should be checked 2 weeks after the infusion prior to considering the dose or restarting the oral iron supplements. This slide shows that some preparations of the parenteral iron. Iron sorbitol, iron sucrose, and low molecular weight esterins. Iron sorbitol is a severe anaphylactic reaction, some GI side effect, pain at ingestion site. Iron sucrose, it should be stored below than 25 degrees C. That stores require some side effects, some contraindication. hypersensitivity, not for the IDA. So also iron, low molecular weight strength is can be given in the large dose, but that dose require limited study in pregnancy contraindication in the first trimester. Only my adverse effects. Now the preparation is FCM. This characteristics you have already seen in previous speaker slides. So what is possible? FCM is capable to deliver substantial amount of iron in single dose, simple administration, so more effective in managing the iron deficiency compared to others. Despite the initial cost, now more accessible in various health settings. FCM is favored in the third trimester for women with less than 10 gram per cent hemoglobin level due to its proven efficacy and safety and convenience of the single-use and cost effectiveness. It is recommended to monitor for about 2 hours after administration to ensure the safety and efficacy. So regarding with the parenteral iron, in practice, parenteral iron therapy is essential who non-compliant with the oral due to the GI side effects. Intravenous iron is suitable for the moderate to severe anemia when the oral ions are inadequate, providing the faster correction of iron deficiency. This intravenous therapy is typically initiated in the second trimester of the pregnancy when the hemoglobin level less than 8 to 9. Areas where the anemia prevalence is high and severe, intravenous therapy is mandated when the hemoglobin level fall below 8 to 9. Parenteral iron therapy is a rapid correction of the iron deficiency during pregnancy is crucial to promptly increasing hemoglobin level, ensuring maternal and fetal death. These studies, these slides show the some studies in India, so also multi compared study the efficacy and safety of the FCM compared to the other parenteral iron with the oral iron. Most of the study show that these FCM significantly improve the hemoglobin and ferritin level as well, and they are suitable for to use in the during pregnancy without serious adverse effect. In the multi-center RCT as well as iron trial in Africa, there's a significant improvement in the iron, improve the iron serum ferritin level. Another option is a blood transfusion. It's a treatment of choice for the severe anemia when the hemoglobin level less than 7. It caused the iron deficiency anemia without replenishing iron store. There's a risk, acute risks like hemolytic reaction, allergic reaction, febrile reaction. As well, delayed reaction like graft-versus-host reaction, hemolytic reaction, iron overload. It's not available in all health settings, and it needs observation. A donor is required. Administration time is about 4 hours. So what is possible? Blood transfusion. Treatment strategies of the switching oral to intravenous, like FCM, has proven effective. Only fewer than less than 1% need blood transfusion due to complication. Most prefer to avoid due to viral, non-viral, and parasitic transfusion reaction. So this slide shows the some guidelines indicated for regarding the management of iron deficiency anemia. SOGP guideline, high dose IV iron FCM should be given to the pregnant woman in second and third trimester. Postpartum care patients should be given a single shoot of the high dose IV iron FCM. Effective options for quick correction of INDA. PMC women have also state that single dose of the 1,000 milligram FCM infusion is safe and effective in the treatment of IDA in women. FCM improve the laboratory biomarkers of these markers level, restore the iron store in short duration time. AGOG also state that it is safe and well tolerated with a superior efficacy in the treatment of the postpartum iron deficiency anemia. CDC and ACOG as well, the United States Preventive Service Task Force, all recommended routine screening for iron for anemia during pregnancy, and CDC and ACOG recommend low dose iron supplementation 30 milligram per day for all pregnant women. WHO also state that the daily oral iron and folic acid supplementation 30 to 60 milligram elementary iron, 400 microgram folic acid is recommended for pregnant women to prevent maternal anemia, diphtheria, sepsis, a low birth weight, and preterm birth, 60 milligram per day iron supplementation for all pregnant women. British guidelines do not recommend any routine iron supplementation in pregnancy. So what are the challenges? Low adherence to the iron supplementation among the pregnant women. One, infestation and nutritional deficiency. Poor monitoring. That's that there are gaps. Patient education, ignorance of the anemia symptoms, inconsistent iron use, intolerance to oral, traditional refraining foods, awareness of the traditional iron-rich foods, including the course of the treatment issue with the patient compliance, fail regular follow-up visits. These are challenges. So how will prevent? Nutritional education, optimal bath spacing, fortified food, nutritional education, hemoglobin estimation, iron and folate supplementation, and promote safe water and sanitation hygiene, control the helminth infestation, prevention and treatment of chronic infection, treat the condition of the causing the blood loss, promote the reproductive health, and in private sector, promote the production of the iron micronutrient and fortified foods and family planning. So I would like to give that some take-home message. Most pregnant individuals do not have the sufficient iron store. Because of the lack of the satellite definition and screening and treatment recommendations, some pregnant individuals undiagnosed. Consistent association between the maternal isolated iron deficiency as well as poor neurodevelopmental outcomes. Isolated iron deficiency as well as INDA have a both negative maternal and neonatal implications. Oral therapy is poorly tolerated and now increased efficacy and reduced side effects offered by the intravenous iron formulation. It is better tolerated and serious side effects are rare. RCT is still needed, critical to guide prenatal providers on iron supplementation, improve the reproductive health and quality of life, millions of the pregnant mother. So conclusion. IDA is a major public health concern. Its effective management necessitates the multifaceted approach, including the regular monitoring, timely diagnosis, tailored treatment strategies. Enhancing dietary iron absorption is vital, especially resource-limited area. Both oral and parenteral iron supplementation play a crucial role, with IV formulation like FCNs providing the faster and more convenient correction of the IND, especially during later pregnancy stage. Public health initiatives have made a significant progress in mitigating the severe IND through free iron supplementation in government hospitals and patient awareness campaign. Nevertheless, challenge persists, including the treatment adherence and limited healthcare access. So comprehensive strategies combining these areas are required, combining dietary modification, appropriate oral and parenteral iron supplementation, patient education, adherence to treatment protocol, ongoing the public health efforts. They are all essential to reduce the IND, ultimately improving the maternal and fetal health outcomes. That's my last slide. Coming November 26 is a World Iron Deficiency Day. This day is dedicated to raising the awareness of the iron deficiency and iron deficiency anemia as a global health concerns. For target population, it's necessary to educate them about the importance of the healthy iron levels and encourage them to seek a medical treatment if they have symptoms. As for clinicians, we need to improve our knowledge and follow our update management and plans, management plans and guidelines depending on the situations and resources. For all the pregnant mothers, these measures are critical to promote safe motherhood. Vielen Dank. Thank you.
Thank you, Professor Munini, for your very informative talk regarding anemia in pregnancy and its management. Best, could you come and sit here? Well, before going to the Q&A section, we have decided to listen the drug presentation by Miss Ipio from Wakat Company. Because some of the questions asked online, the answers will be included in drug presentations.
Hello ဆရာဟုတ်ရပါပြီဆရာဟုတ်တယောက်ချင်းမြင်ပြပါတော့ဆရာကြီးဆရာမကြီးများနဲ့ဆရာတို့မတို့အားလုံးပဲအထူးကျေးဇူးတင်ပါတယ်ရှင်ညီမဒီနေ့ကတော့IgA အတွက်ပေါ့နော်သုံးတဲ့ ion injection လေးကိုFakari လေးနဲ့မိတ်ဆက်ပေးချင်ပါတယ်ညီမကတော့ product manager ဤဖြိုးပါFakari ကကြတော့ညီမတို့10 မေပါရဲမှာဆိုလို့ရှိရင် ferrous carboxymaltose က500 mg ပါပါတယ်သူကတော့ဒီ oral ion ပေါ့နော်အဆင်မပြေတဲ့ patient တွေအတွက်ကို IgA မှာသုံးဖို့ကို US FDA ကို2013ကရရှိထားတာဖြစ်ပါတယ်ရှင်အဓိကအားသာချက်လေးကတော့သူကတော့ single dose ပဲသုံးဖို့လိုအပ်ပါတယ်ဒီ single shot therapy ပေါ့နော်500 mg 1 vial လည်းသုံးလို့ရသလို2 vial ဖြစ်တဲ့ဒီ1000 mg ကိုလည်းပဲ single dose နဲ့သုံးလို့ရပါတယ်ရှင်သူရဲ့ mechanism action လေးရလည်းပဲသူက hemoglobin level ကိုတက်စေသလိုသူကကြတော့ဒီ ion store အတွက်လည်း replenishment ကိုဖြစ်စေပါတယ်ရှင် ion replenishment အတွက်ဆိုလို့ရှိရင်သူကတစ်ပတ်ကိုပေါ့နော်1000 mg ကိုပေးလို့ရပါတယ်ရှင်သူရဲ့ administration ကကြတော့ IV injection ပေါ့နော်ဒီ IV injection ကို direct လည်းပေးလို့ရတဲ့ပြင်0.9 sodium chloride နဲ့လည်းပဲ dilute လုပ်ပြီးတော့သုံးလို့ရပါတယ်ရှင်ညီမတို့ Fakari မှာဆိုလို့ရှိရင်တော့10 မေမှာ ferrous carboxymaltose က500 mg ပါပါတယ်ရှင်ဒါလေးကတော့ body weight နဲ့ပေါ့နော်ဒီ hemoglobin level ကိုလိုအပ်တဲ့အားလေးကိုပြထားတာပါဒီ below 35 kg ပေါ့နော်ပြီးတော့35 kg ကနေပြီးတော့70 kg 70 kg and above ပေါ့နော်အဲ့ဒါလိုအပ်တာလေးကတော့သူကbelow 35 kg ဆိုလို့ရှိရင်တော့သူက500 mg လိုအပ်ပါတယ်ရှင် less than 10 hemoglobin level က10 to 14 greater than 14ပေါ့နော်ဒီသုံးခုလုံးကိုဆိုလို့ရှိရင် below 35 kg ဆိုလို့ရှိရင်တော့500 mg ပဲလိုအပ်ပါတယ်35 kg and 70 kg ကြားဆိုလို့ရှိရင်တော့သူကတော့နည်းနည်းအပြောင်းလဲလေးရှိပါတယ်hemoglobin က less than 10ဆိုလို့ရှိရင်တော့1500 10 to 14ဆိုလို့ရှိရင်တော့1000နဲ့greater than 14ဆိုလို့ရှိရင်တော့500 mg လိုအပ်ပါတယ် body weight များတဲ့ဒီ70 kg above ဆိုလို့ရှိရင်တော့ less than 10ဆိုလို့ရှိရင်တော့2000 mg ပါ10 to 14ဆိုရင်တော့1500 mg နဲ့ greater than 14ဆိုလို့ရှိရင်တော့500 mg လိုအပ်ပါတယ်ရှင်ဒီအောက်ကကြတော့ dosage လေးနဲ့ပေါ့နော် dosage ကကြတော့body weight နဲ့ချိန်ပြီးတော့ပေးမယ်ဆိုလို့ရှိရင် IV injection ဒါလိုက်ပေးမယ်ဆိုရင်15 mg per kg နဲ့တွက်ပြီးတော့ပေးလို့ရပါတယ် infusion လေးပေးမယ်ဆိုလို့ရှိရင်တော့20 mg ကို kg နဲ့ချိန်ပြီးတော့ပေးလို့ရပါတယ်ရှင်သူကတော့ဒီ maximum ပေါ့နော် recommend dose ကကြတော့ဒီ accumulation dose ကတော့1000 mg ကို per week ပါရှင်ဟုတ်ဒီညီမတို့ဒီ Fakari ကိုထိုးပြီးတဲ့အခါမှာဆိုလို့ရှိရင်၄ဘက်ကြာရင်ပေါ့နော်ဒီ hemoglobin ကိုစစ်ပြီးတဲ့အခါကျရင်လိုအပ်လို့ရှိရင်တော့ထပ်ပြီးတော့ထိုးလို့ရပါတယ်ရှင်ဒါလေးကတော့dosage ကိုအလွယ်ပေါ့နော်အလွယ်မှတ်တဲ့အခါမှာဆိုရင်hemoglobin က greater than 9ဆိုလို့ရှိရင်တော့ညီမတို့ Fakari တစ်လုံးကိုဒီ100 ml normal saline နဲ့ရောပြီးတော့30 minutes သုံးလို့ရပါတယ်ရှင်ဒီ6 to 9ဆိုလို့ရှင်တော့ Fakari ကနှလုံးကို250 ml normal saline နဲ့ရောပြီးတော့ duration ကတော့30 minutes to 60 minutes လောက်ပေါ့နော် slow infusion လေးနဲ့ပေးလို့ရပါတယ်ရှင်သူကတော့ဒီတစ်ပတ်ထဲမှာတော့ပေါ့နော်အများဆုံးကိုဒီ1000 mg ပဲသုံးဖို့အတွက် recommend လုပ်ထားပါတယ်ရှင် သူရဲ့ indication ကတော့ညီမတို့ oral နဲ့ပေါ့နော်အဆင်မပြေတဲ့ဒီ IDA တွေမှာဆိုလို့ရှိရင်သုံးလို့ရပါတယ် pregnancy CKD heart failure နဲ့ဒီ inflammatory bowel disease တွေမှာဆိုလို့ရှိရင်တော့ညီမတို့သုံးပါမယ်ဒီ Fakari ရဲ့ဒီအဓိကအားသာချက်ကတော့ safe ဖြစ်တယ်ပေါ့နော် well tolerate ဖြစ်တယ်ပြီးတဲ့အခါမှာအဓိက single dose ပေါ့နော် single dose ဖြစ်ပြီးတော့သူက no test တို့ require ပါ hemoglobin level တက်တာမြင်တယ်ပြီးတဲ့အခါမှာဆိုရင်ဒီ postpartum anemia မှာဆိုလို့ရှိရင်လည်းပဲဒီrecommend လုပ်ထားတယ်ပေါ့နော် AGOB နဲ့ OG နဲ့ BNC ကနေပြီးတော့ recommend လုပ်ထားပါတယ်အဓိကအားသာချက်ကတော့သူက reaction ဖြစ်တာအရင်နေပါတယ်ရှင်ဟုတ်ဒါလေးကတော့ Fakari နဲ့ bread transfusion ကိုရှင်းပြထားပါ Fakari ကတော့ no test တို့ပါပြီးတော့ ease of administration ပေါ့နော်တစ်ချိန်မဲ့ထိုးရတာဖြစ်တဲ့အတွက်ကြောင့်အရင်ကိုအဆင်ပြေတယ် hemoglobin level တက်တာမြန်တယ်ပြီးတော့တစ်ချိန်မဲ့ထိုးရတာဖြစ်တဲ့အတွက်ကြောင့်ပေါ့နော်ဆေးရုံကိုခဏခဏလာစရာမလိုဘူးပေါ့နော်ဒါပေမဲ့ bread transfusion ကြတော့ allergic reaction တွေတွေ့နိုင်တယ်ပေါ့နော် infection တွေrisk ရှိနိုင်တယ် donor လည်းရှာဖို့လိုတယ်ပေါ့နော်ပြီးတဲ့အခါကျရင်ဒီ blood transfusion ကြတော့ iron store ကို replenishment မလုပ်ပေးဘူးပေါ့နော်ညီမတို့ Fakari ကကြတော့ဒီ iron store ကို replenishment လုပ်ပေးပါတယ်ရှင်Fakari ရဲ့ဒီ summary လေးပြောရမယ်ဆိုရင်အဓိကတော့ hemoglobin level တက်တာမြင်တယ်single dose ပဲသုံးရတဲ့အတွက်ကြောင့်အရန်ကိုအဆင်ပြေရပေါ့နော်no test တို့ require ပါပြီးတဲ့အခါကျရင် reaction အရန်နေတဲ့အတွက်ကြောင့် better safety profile ဖြစ်ပါတယ်ရှင်ဒါကြောင့်မို့လို့ဒီဆရာကြီးတို့မမတို့ရဲ့ patient ကIDA အတွက်ပေါ့နော် IDA အတွက် iron injection လေးသုံးဖို့လိုအပ်ပြီဆိုလို့ရှိရင် Fakari လေးသုံးဖို့အတွက် request လုပ်ပါရရှင်ဟုတ်ကျေးဇူးများတင်ပါတယ်ဟုတ်
Thank you, Ms. Ipu, for your product presentation. Now we're going to start our Q&A section, and now the floor is used for Q&A. Yes, I've obtained, some of the questions raised from the online, but here we'd like to, ask the audience to start your questions here. Any comments or any questions? Okay, Sarah Deepa.
Practical point လေးတစ်ခုပဲပေါ့ကျွန်တော်တို့ကစေကနေမှတွင်းတော့မယ်ဆိုရင်ဒီဟာကို normal စေလိုက်နေပဲတွင်းလို့ရမယ်ဒါမှမဟုတ်လေ glucose နဲ့တွင်းတော့ဘာပြဿနာရှိတယ်တကယ်လို့ water for injection နဲ့တွင်းရောဘာပြဿနာရှိတယ်အဲ့လိုလေးပြောထားလိုက်ရင်တော့ဒါဆိုတွေ့ရတဲ့စောက်တွင်းတွေမှာဆိုလို့အဲ့ဒါလေးကိုကျွန်တော်နည်းနည်းလေးပြန်ပြီးတော့အားလုံးအဲ့ဒါလေးသိပေးစေချင်ပါတယ်ဘယ်လိုဖြေလို့ရပါလဲ
Thank you, Asya. According to the drug presentations, it's specifically mentioned that diluent should be normal saline. I'm not sure, whether you can use 5%. I'm going to respond for that.
head office ကပေးတဲ့ slide ထဲမှာဖတ်ထားတဲ့အခါမှာဆိုလို့ရှိရင် तू က normal saline တစ်ခုတည်းနဲ့ပဲသုံးလို့ရမယ်လို့ပြောထားပါတယ်။ဘာကြောင့်လဲဆိုရင် तू ကအဲ့ဒါနဲ့မှ stable ဖြစ်လို့ပါရှင်။ဟုတ်။တန်တဲ့ဟာတွေနဲ့ကြတော့ရောဖို့အတွက်ကို recommend မလုပ်ပါဘူးရှင်။အဲ့တမျိုးတည်းပဲရပါမယ်နော်။ဟုတ်ကဲ့ပါရှင်။ကျေးဇူးပါရှင်။
Thank you. Continuation with this question, may I ask another question for Professor Khan? This is asked online. What's the protocol for iron infusion with this drug in general practice for pregnancy, as it is not without risk? Have you been using in your, outpatient setting, or if so, could you share your experience, please?
Thank you very much for your question. I've been using it for our hospital has been using it for the last 8 years. This Fercari has come up over the last 5 years, but before that, Ferinject was being used. And we have a very good experience with it in the sense that the maximum side effects that we had were a bit of dizziness and nausea. And as I mentioned during my presentation, that we overcame those two problems by diluting it further into 500 ml, and that worked for the patient and for us as well. And we are using it on outpatient. We send our patients to the ED, and they follow the protocol, and for inpatients as well, like post-operative anemias, or maybe those admitted for observation for other reasons during pregnancy, like controlling the high blood pressure or GDMs and all those. So during the workup, if it is found that she has iron deficiency anemia, so we transfuse it during their stay in the hospital. So both inpatient and outpatient.
Thank you. And another question is, also related to the IV ferric carboxymaltose. It can cause hypertension according to the literature. And then, is it through your studies? Have you been seeing high blood pressure? Because according to the literature, I've seen that 1 to 4% of patients who can develop hypertension while they were receiving, ferric carboxymaltose, which is quite negligible in number. What about your experience, please?
During the pregnancy?
Giving this
High blood pressure, yes.
experience of raised blood pressure.
High blood pressure, we do monitor the patients before starting the infusion, right? During the course of infusion, because it takes about 45 to 1 hour time. So every 15 minutes, the blood pressure and pulse and oxygen saturation is checked. And then for half an hour after finishing the infusion, we keep a check on the patient every 15 minutes. So we haven't seen, outpatients, we haven't seen any increase in all right. Yeah, thank you. So we haven't seen any increase in blood pressure in the patients, but those with high blood pressure, yes, sometimes there is slight increase, and then we reduce the rate of, it might be because of the 500 mLs that we are extra giving to the hypertensive patient, it might be the reason, or maybe it's the ferric carboxymaltose, we don't know yet. So we reduce the speed of the infusion. So that helps us, and we are okay with it. This is my personal experience. I'm not talking about the literature, what it says.
Yes. Thank you. Any questions from the audience? Another question is IV iron carboxymaltose minimum dose in 1 week and 1 month. I think that was answered by the recipio in our presentation. And another one is there any prospective observational studies in pregnant anemic women in Pakistan?
Yes, we are keeping a record of that. There is a study going on, but we will end it in 26, end of December 26. So there's some time left for that still. Yeah, by the end of next year, inshallah.
If there is no questions from audience, may I continue the questions from online or?
May I add one thing, please?
Yes.
I always tell my PGTs and my junior staff that we generally follow the books written by the Western authors, right? And their circumstances are much different than ours. You just saw that there is no recommendation by who was not nice, or RCG, something mentioned like this. They haven't mentioned recommended any iron dosage. Basically, their women are not anemic. Their foods are fortified, right? Then they have an opportunity to have good nutrient, to maintain their good nutritional status. But these are our problems, right? In the South Asia, in the sub-Saharan African countries. So there's, according to the WHO, 87% of the anemias is either in the sub-Saharan countries or in South Asia. Of this, 70% is there and 17% is in our area. I would request, there's so many senior faculty sitting here, yourself and everybody else, that if we can have some collaboration in research in different fields regarding not just this topic, but other topics that you might come up with. So through the societies or maybe on individual basis, we can collaborate and do some mutual work so that our patients can benefit, and we can develop some local guidelines, So that will be helpful for us and for our patients as well, receiving a uniform sort of care in Myanmar, in Pakistan, in all those places.
Yeah, the
So,
Medicine Society also requested me, to do such collaborative activities.
exactly. So I'm again requesting the same.
Yeah.
It can be done through the societies and it can be done on individual basis as well.
Thank you. Because when we have a meeting in Ho Chi Minh City and Shanghai, I've met some endocrinologist physicians there, and they also, talked about collaboration between Myanmar Indian Medicine Society and the Pakistan Indian Medicine Society in the future. All right. Another question is for Professor Heyada. Iron deficiency, regarding iron deficiency, anemia, and heart failure and CKD. Part of the iron deficiency is correctable and improves disease outcomes. I would like to know, how frequent do we need to check iron study to identify and monitor for iron deficiency anemia in those diseases? Is there any role of the oral iron supplement in these patients? I think he has already talked in his lecture, but could you repeat to answer for that, please? Now tell me.
Yeah, thank you very much. I think it's very interesting question. Yes, I already mentioned that we should monitor the hemoglobin percentage monthly, and then iron study 3 monthly. We have to check the serum ferritin and DSAT 3 monthly, so that it's more than enough. And then if it is stable, then we should check yearly for the iron studies. So I think I'm answering the first question. Regarding the second question, role of the oral iron preparations in the management of anemia in heart failure and CKD, I'd already mentioned that according to the iron out study, oral iron therapy is not effective, and then at the same time, it can increase the risk as well for so many reasons, because the absorption is poor. And then we have another character played in the significant role in the pathogenesis of iron deficiency in these sort of patients, which is the hepcidin. Hepcidin level is very high, so that when we give the oral iron preparation in these sort of patients, and then if that particular patient has high hepcidin, it's not working well, so that iron therapy is not routinely recommended. But we should consider which might be useful after parenteral FCM. So in some rare conditions like if the patient is having minor bleeds or some sort of minor symptoms regarding stable, then in these sort of patients, we should consider following oral iron preparations after parenteral ferric carboxymaltose. So I think I'm answering the second question as well. Thank you.
Thank you, Professor Heyaza. One more question is, if major operation is planned on the next 3 days, hemoglobin was only 9, can we use parenteral iron instead of blood transfusion? Can it be effective within 3 days? Definitely not, We have to wait, at least 2 weeks to have action of the iron upon the bone marrow to produce more RBCs. That's why, if a patient is anemic and symptomatic, the best way is to give blood transfusions. Oh. Another one is how to manage iron deficiency anemia with hemoglobin E disease before and after pregnancy. I think in Southeast Asia, it's common to have abnormal hemoglobins like hemoglobin C and hemoglobin E, but majority of them, they have a very mild anemia. We don't need to, give a specific treatment for them. But if you find combined iron deficiency anemia with hemoglobin abnormalities, you should treat the iron deficiency. But for the hemoglobin E disease, there will be no specific treatment apart from some folic supplements. I think that's all, asked by the online. And may I ask, Kane, any question from the audience or any comments? And yes, Professor Tolonye.
Thanks for the all speakers. And I would like to give the two comments and the one questions to the Professor Khan. The one comment is that whenever you want to diagnose the iron deficiency anemia, when you test the iron study, please test on the both serum iron, TMBC, and ferritin. Not only ferritin alone or iron alone or TMBC alone, because when we need to interpret the iron study, these three tests should be done. So that is why the ferritin plus TZ is the serum iron divided by TMBC into 100. So TZ percentage is very important, especially in the presence of anemia or chronic disorder or inflammation. So ferritin plus TZ and ferritin. So that is a one comment. Please take the iron study completely to show the evidence of the iron deficiency. Another comment is that when you consider the anemia in the patient as a whole, anemia causes is not only due to the one cause. So please keep in mind that the cause of the anemia will be the more than one cause, both iron deficiency as well as the other blood loss or other chronic disease or hemolysis or something like that. So whenever you better keep up the combination of the causes of the anemia, so it should be keep in mind. Iron therapy should be applied to only in patients with evidence of iron deficiency anemia, not for the other causes of the anemia. You all know that iron is only the one-way regulatory mechanism, no external come out from the body. So whenever you give the iron, all the iron should be stored in the body, no come out. So if it is iron therapy is not necessarily used in the patient, not due to the iron deficiency anemia, iron overload will be the problem. This is two comments. The questions is as by the, and I would like to share about what about the oral iron therapy with intravenous iron therapy. Usually oral iron therapy should be withheld or during the IV parenteral iron therapy because of the, when you both simultaneously oral iron therapy and intravenous iron therapy simultaneously, oral iron therapy effect is not good. Why using the IV iron therapy? What is your opinion of oral iron therapy followed by IV or simultaneous use?
So yeah. I think, yeah. Thank you for your question. It basically depends upon the baseline hemoglobin level that we get and the result of the iron studies. So if the hemoglobin is above 11, we just continue with the oral iron. There's no, and the iron stores are also good enough. So we don't give them any IV iron. They continue with oral supplements because they do need extra iron for, as I mentioned in my talk, that they need extra iron for not only for improving the HP, but for working of certain enzymes and for the growth of the fetus as well. So that extra demand is met by the oral iron. But we are talking about actually the anemic patients, and in in anemic and those with the depleted iron stores. So in those cases, yes, during the time when we are planning to give them the IV iron, for the next 4 weeks, we do not give them oral iron. So IV iron will work. We'll check the hemoglobin and not the stores, but the hemoglobin in about 4 weeks time. And then these are checked in 8 to 12 weeks time, the iron stores. And then we decide whether we are going back to oral or does she need another dose of IV iron. Thank you. I hope it clarifies your question. Yeah. Thank you. Exactly. Yes, exactly. So basically, it is for the anemic and the store depleted. Otherwise, for maintenance, we give them oral iron as a routine during pregnancy. Yeah. Our foods are not fortified. Our women don't take enough balanced diets. So they do need these supplements. Yeah. Thank you.
Yes, thank you very much. Professor Rimra.
Thank you. A very good seminar today. A comment, and maybe you can call it a question. The first comment is, the thalassemia is very common in this country. So let's say beta thalassemia trade, you will have about 5% of this in the population. So if you have a beta thalassemia trade, if you have iron deficiency, it'll suppress, the level of hemoglobin A2. So it won't appear, you do a blood test, you find iron deficiency anemia. And only after you've treated iron deficiency anemia, hemoglobin A2 or thalassemia trait will appear in the bloodstream. But you are not aware of it. I think this is important because if the mother is carrying this hemoglobin beta thalassemia hemoglobin trait, then you'll have to think about, the baby carrying this also, and you have to test the husband and things like that, you see. So this has some implications. So I think it's important, you treat the iron deficiency in pregnancy, and then sometimes, afterwards, hemoglobin A2 might appear. So this is a comment. The question, or rather I'm asking your opinion, is about the dose of oral iron. Sometimes doctors are very enthusiastic and then they will prescribe, let's say, ferrous sulfate, 2 tablets 3 times a day, or, or any other oral preparation. So what do you think about this high doses of oral iron preparation? Do they have bad effects? Or, or you just stick to 1 tablet a day? Because I think this is implications, because sometimes, doctors, they like to have a quick response and then they give high doses of oral iron. So can I have a comment, please?
Thank you for your comment, and thank you for highlighting the importance of looking for other causes of iron deficiency anemia as well. Hemoglobinopathies are very common in our area. I come from north of Pakistan, and I am in a place which is very close to the border with Afghanistan. So on both sides of the border, because we get patients from Afghanistan as well, they don't have good medical facilities over there. So they come, we have this medical tourism sort of thing in our place. And they come, so patients on both sides of the border, there's a big border between Afghanistan and Pakistan, and living those on this side and on that side, hemoglobinopathies are very common, especially because we have intermarriages. There are certain families that they do not marry from outside the families, So this even increases the risk of having full-fledged thalassemias, not just the trait. So when you have a patient with anemia, so we correct the anemia first, and then we definitely check the HB electrophoresis, send them for HB electrophoresis, because that's sort of a routine. In 2 months' time, we do check that. It has implications, especially, and we can do it early if the patient is in first trimester, because as you know that If hemoglobinopathies are there and the husband is positive as well, then you need to send the patient for CVS. And CVS is between 10 to 14 weeks time. So then we check it a bit early. If the husband comes with his HB electrophoresis also gets back normal, as a trait carrier. So then we check early. But in routine cases, when the husband is negative, after 2 months, we check the HB electrophoresis. Okay. And regarding your second question of the dosage of the oral iron, as I mentioned in my talk, that the Society of Obs and Gynae in Pakistan has recommended 30 to 60 milligrams of oral iron per day, and that's enough. And this should be followed when specific instructions need to be given that this should not be taken with the calcium or milk products. Rather prefer to take orange juice is not available to our women. Those who are anemic, they don't have orange juices, but at least they have lemon at home. So you basically need citrus. So we ask them to take it with a glass of fresh lemonade, which is available, easily available. And it has to be taken before the meals, either 3 to 4 hours before the meals or 2 hours after the meal. And during that time, no calcium, but citrus.
Because lots of, let's say, some general practitioners, for instance, they will prescribe ferrous sulfate 2 tablets 3 times a day.
Yes.
So is it harmful? Because, there are views that you shouldn't be, it's actually harms the body
Exactly.
instead of giving a beneficial effect. So, just a little explanation from you how it harms the body, so.
Yeah.
Yeah.
Response to that question.
All right.
Because in here, like CIG Prof mentioned that we give too much iron preparations in our daily clinical practice. Whenever we are talking about the iron therapy, we have to consider the elemental iron, that is the biologically active iron absorbed from the gastrointestinal tract. We need roughly 100 to 200 milligrams per day of the elemental iron. If we prescribe the ferrous sulfate formulation, let's say 325 milligrams, then the elemental iron will be 65 milligrams. So that if we want to maintain the 100 and 200 milligrams per day, we just need to give only 1 TDS. So I think we have to avoid the massive doses of the iron preparations because we have to maintain the elemental iron between the 100 and 200 milligrams per day. Thank you.
The other part would be that it has side effects as well. There is nausea, there's diarrhea. Some patients can experience constipation with it. So by giving high doses, these side effects would be more prominent. And the other thing is that even if you give high doses, they will be excreted. So that will be harmful for the mucosa of the intestinal tract as well, besides giving these symptoms. Yeah.
First of all, I would like to congratulate all the speakers who have highlighted the very important issue especially for the pregnant woman. Because I'm an obstetrician, so that from the obstetrician side of view, so I would like to congratulate all of you. Because anemia is very common in Myanmar, also among the pregnant women, and leading to the maternal mortality, and also it can aggravate the obstetrics causes of death, especially the postpartum hemorrhage and puerperal sepsis by having the pre-existing anemia. So that because today the audience is also a mixture, mixing from GP, obstetrician, physician, and the messages you all have sent to us is very important, because the first one is for the population, we need to increase to reduce the anemia by giving the health education and to choose type of food. It's a method of food preparation to to improve the nutrition. And also the supplementation, as also the WHO and all the guidelines, they have advised to give the supplementation. And there's a lot of methods to give the supplementation, but now we are also fighting a part as an obstetrician and also the public health workers giving the supplementation. But I would like to highlight about the diagnosis. Diagnosis of anemia is very important so that we all, I think the audience also have an idea to diagnose anemia and the causes of anemia, as the professor highlight about the causes is very important, especially the worm infestation, especially for the gynecologists with a chronic abdominal pain or pelvic pain. It is sometimes associated with having worm infestation. So these are we have idea to identify the causes of anemia and then to give the treatment to prevent the anemia. Then I got the questions to all you. It's a type of supplementation by oral and also the parenteral. But for the parenteral, as in our younger age, we are worried about anaphylactic shock with this parenteral iron therapy. You still give the no test dose, but there's sometimes it's a very rare chance to have an anaphylactic shock. So I'd like to give any of you to give the advice to the audience to prevent or to save life if there's anaphylactic shock, especially in the GP setting, to give the IV and the parenteral iron. Thank you.
Thank you very much. There's a set protocol for infusion of this IV infusion of ferric carboxymaltose, and we check the hemodynamic status before infusion, during the time of infusion, that 1 hour, and afterwards as well. And we in our setup, we do it in our ED, the emergency department. And obviously the emergency department are observing well, and then they have all the preparations to respond to any anaphylactic shock. In my experience of almost 8 years with carboxymaltose, taking all the precautions, we haven't seen anything yet. And touch wood, we haven't seen anything, and I hope we don't see. The thing is basically to gain your confidence, I would strongly suggest that you follow the protocol. And follow the protocol, do it slowly, give it in diluted form. You will definitely have good results. And then this needs to be done because you see anaphylactic shock may or may not occur, and even if it occurs, it will be for a very small percentage. But look at the other percentage of women who will be getting advantage of this infusion, you know. It is less than 0.08, 0.8 in 10,000 women, right? So which means less than 1. So 9,999 women are getting advantage, you know. So we should be to have the full protocol and then give advantage to those 999 women, you know, 9,999 women. So it is worth trying, and hopefully at some other time I'll share you will share your experience regarding this thing with us. Thank you. I hope this clarifies it.
Yes, thank you, thank you for your questions. And I checked the literature as well. For the parenteral ions, available ions, iron dextrin, iron sucrose, and iron ferric carboxymaltose, etc. In those parenteral forms, they only suggested to do the test dose only for iron dextrins, not for the others. But the protocol is strictly mentioned that how to dilute and how to give the rate of infusion and how to monitor all the things and how to watch, only after infusion at least 30 minutes. Those are the things, and that's why this course is only required for the iron experiments, not for the others.
Hello.
Thank you very much. We will just let you go ahead with the one final question from the online. He has asked whether the pregnant woman who had a hemoglobin of 8 gram at 38 weeks of gestation, and supposing that that lady had a normal spontaneous vaginal delivery without any complication, he was asking whether he should recheck the hemoglobin or give transfusion. I think this is individual cases. If he thinks that if you recheck the hemoglobin after 2 to 3 weeks, and if he think she need more iron, he can choose whatever the type of the iron supplementation she preferred. Like to say?
Yeah.
Okay.
Keeping in view the medical system, the healthcare system in our countries, where the patient would hardly come for delivery and then you won't see her till her next pregnancy, this, if you wait for 2 to 4 weeks to check all this, you'll never get the patient back. I hope some of your patients might be like this. Even I'm in an urban setting, and even there, patients may not be very compliant with the follow-up visits. So what I would suggest is that 8 grams means that up to 500 ml of blood loss is considered normal for in a normal pregnancy. So it means after delivery, the HP would have come down further, and then she will be lactating in the postpartum period, where the requirement for the iron is increased even more. So in my opinion, after the delivery, the HP should be checked. If it is anything less than 8, you go for blood transfusion. But if it is less than 7, sorry, then you go for blood transfusion. But if it is anything above that and still anemic, IV iron is the best shot for her. And then after 4 weeks, for 4 weeks, you check. If you have the opportunity, you can check the HP again, whether there's another need for it or not. And if not, if she's not going to come, you think she's not going to come, then you can prescribe her oral iron to be taken after 1 month for the time that she's lactating.
Okay, as the time is running short, by the permission of Chairperson Professor Ayal, may I conclude these sections by giving conclusion remarks. Today, three eminent speakers were talking about the three important topics. The first one is anemia in pregnancy, and then how to manage the anemia, different degrees of the anemia in different trimesters with the different, administrations, oral as well as parenteral. Majority of the pregnant women, they can be managed by the oral iron therapy, but only certain conditions they need to be given parenteral iron therapy. Both speakers highlighted the role of the iron therapy, especially ferric carboxy maltose, by showing the various trials and then some beneficial effects of using this particular drugs. The second important topic is heart failure and iron deficiency. This is very popular about 2-3 years back. Even with the iron deficiency, the patient may not have anemia. In such case, if you correct the iron deficiency, the number of hospitalizations will be reduced, and exercise performance and quality of life will be improved. This is a definite findings by the various trials highlighted by the Professor Heyaza on FARM HF, CONFIRM HF, and FAIR HF, etc. That's why the class recommendation for the ESC is 1A. Patient with a heart failure, if you find iron deficiency, and iron deficiency, even in the absence of the anemia, only by means of the parenteral iron therapy, not by oral therapy. And last but not the least, the last topic is a very common problem in our daily clinical practice, like a chronic kidney disease. Anemia is very common. We use of the anemia, but many people they were managed by the oral ion therapy. As Professor, we highlighted that different doses of the ion therapy, but majority of them they can't tolerate the high dose because of GI upsets and the chronic kidney disease, uremia, and even with that, some of the clinicians they are not aware that the side effects of the oral ion therapy, and in such case they might need the parenteral ion therapy. I would like to thank all the speakers. Professor Satwit Khan from coming from a very far place, Pakistan, and Professor Hayazao and Professor also come from Magui. I'd like to thank all the speakers by sharing your experience and giving much information to the audience. Secondly, I'd like to thank the work that the company was sponsoring this event, and last but not the least, all the attendees coming here directly and finding online. Now, I'd like to conclude the section by giving again, thank you to all.
May I please invite Mr. Shudenshu to give the vote of thanks.
Benglaba. Well, I'm really delighted to see such a distinguished audience today here. Hardly we get an opportunity to see our medical fraternity from such a diverse background. We have OG-GYN, we have hematos, we have endos, we have physicians, general practitioners, all are here for this symposia. So we thank you from the bottom of our heart that you have taken out your time for this symposia today. Very special thanks to our speakers and chairpersons who really took it on as it was a very new topic, a very new area where much has not been spoken about the IV iron thing, where a lot of apprehensions were there from the society. So that all have been well taken care of, have been addressed well. So thank you very much, each one of you. Thanks a lot, professors and speakers and chairperson. Thanks a lot from my side. Thank you.